Doctors, we are live.
Okay, shall we start the webinar? Okay, Sai.
Yes, Doctor, you may go ahead.
Good evening, good morning, good afternoon for people who are in all parts of the world. On behalf of the Shankar Netralaya Alumni Association, I have the greatest pleasure of welcoming you all for this wonderful webinar, Uvea and Retina Capsule. As you know, our Shankar Netralaya Alumni Association is one of the strongest alumni associations in the entire country, in the entire world, I would say, with more than 900 members as alumni members who are very, very active, making the alumni a very, very active association as well. I have the greatest pleasure of organizing this webinar, and also 3 months back we had a pan-ophthalmic webinar wherein we had all the subspecialties in ophthalmology, and a record of 42 faculty speakers were there, which was very, very well received and well attended as well. Then we thought, JB gave the idea, Rajiv also gave the idea that we should have capsules, that is 2 subspecialties every month. And we are starting this Uvea and Retina capsule this month. Next month, in the month of December, 3rd week, we are planning to have cataract and cornea. In the month of January, we are planning to have glaucoma and oculoplasty. In the month of February, we are planning to have pediatric ophthalmology and neuro-ophthalmology as well. So all these will come to so that all the alumni will be given a wonderful opportunity, wonderful platform to exhibit their talent. And this virtual, the world, I would say, has become the new normal. I hope everybody is safe. And with these few words, I have the greatest pleasure of welcoming the faculty for the capsule, that is the Uvea webinar. And let me share my screen now. I will share my screen, Sai.
Yes, sir. Please.
Able to see my screen?
Yes. Yes, sir. Yes, sir.
Okay, this is the Uvea and Retina capsule. The Uvea will be approximately for 1 hour. The Retina capsule will be approximately for 1 hour. We have a galaxy of faculty. We have always the blessings of our chief and madam. I spoke to madam a couple of days back and I explained to her about this webinar. She was very, very happy. I was not able to speak to chief, but we always have the blessings of chief and madam for this webinar as well. And of course, our president, Dr. Natarajan, who will be joining us very soon. I am Dr. Mohan Rajan, secretary of this thing and of the Shankar Netralaya Alumni Association. We have the moderator for the Uvea session, none other than Dr. J. Biswas. He doesn't require any introduction. He is the top cream, not only in India, but also in the world. You saw that recently, a record number of 456 PubMed. I should give a standing ovation for JB, and he's been recently conferred the FRCS from Edinburgh as well. And we have, of course, the wonderful panelists here, Dr. Sishir Narayanan, consultant Uveitis and Retina Services Shroff Eye Center in New Delhi. And he's been a wonderful guy, very, very active academically as well. Dr. Manisha Agarwal, who did her vitreoretinal fellowship from SN, and she's also the head of vitreoretina and critical research in Shroff Charity Eye Hospital in Delhi, and 100 peer-reviewed publications, which is simply amazing. Ale Banker, as you all know, done a lot of clinical and research work in Ahmedabad. He's also a former fellow of Shankar Netralaya, and he's done a lot of work on HIV/AIDS as well. And then we have Avinash, and who's Avinash is here. Avinash from Eli Prasad Eye Institute is taking care of the Eli Prasad Vishakhapatnam, a chair of the education, director of academy of eye care education in the entire Eli Prasad group as well. Dr. Salil Mehta, who is a consultant ophthalmologist, Leelavati Hospital, Mumbai, and he is also here to share their expertise and knowledge. Over to Dr. JB, the moderator for the Uvea session. JB, you will introduce the speakers. Yes. I'll put the speakers, continue the slides here. This is a keynote address by Dr. Manoj Khatri. JB, over to you.
Okay. I welcome Manoj here from the Uvea Capsule. And Manoj is a consultant ophthalmologist and vitreoretinal surgery at the Rajan Eye Care Hospital. He was a research fellow of Shankarnetralaya and having academic interest in diabetic retinopathy and age-related macular degeneration. His special interests include diabetic retinopathy and macular hole in the surgical area, and ARMD and pediatric endophthalmitis, retinitis pigmentosa, and retinopathy of prematurity. He has presented several papers in the national and international forum, and he is a wonderful person. That is the only thing which I want to tell you. As such a vibrant person and such a good alumni, SN alumni, I welcome Dr. Manoj Khatri for his talk. Manoj, please.
Other speakers
Then,
also.
And I will take this opportunity to introduce other speakers. Dr. Priyanksha is from Chitrakoot, and he was a junior consultant in Retina and Uvea, and he did medical Retina and Uvea fellowship in SN Chennai, and he had a publications with, I have a publication with him. He is a very good academic person. Next is Risha. Risha and was their fellowship in medical retina and Uvea at Shankarnetralaya. He was from Little Flower Hospital, Angamali, Kerala. We did a paper on 500 patients, 800 eyes of Eels disease, and that has been really Risha's great work, and which has got a lot of recognition. She is also very present. Vijay Tomar is from Sitapur. He is an associate professor of Regional Institute of Ophthalmology, senior consultant in Uveitis and medical retina, head of the community ophthalmology services, Sitapur Eye Hospital, Sitapur. You have to go there to see how is the setup over there, and he is doing a great work. Amit is one of the brilliant fellow up there. He did Uvea, medical retina, vitretina, whatnot, and he is a vitretinal and uveitis consultant, retinal specialty in Indore, and I have got the pleasure of working with him. With this small introduction, we like to go take over, Mohan to take over and introduce and start the keynote address by Manoj.
Thank you, JB, for the nice introduction. And over to Dr. Manoj Khatri for the keynote address, which will be approximately for 12 minutes. Manoj, you can share your screen now.
Yeah.
Thank you very much, sir. Is my screen visible?
Yes, Manoj, go ahead.
Thank you, Dr. JB sir and Mohan sir, for the kind introduction, and don't deserve so much of applause, whatever you have given, but your love and affection of all the ASEAN alumni, I think it's kept us going, and we are getting stronger and stronger. Today's topic assigned to me was patients as partners, and slightly offbeat topic from routine clinical as well as research ophthalmology. I hope I do justice to this. Is basically going that extra mile in our routine patient care. All of us are doing it, but can we do something more, especially in this post-COVID era? So how do we look at patients as partners in this recent epidemic, which has taught us a lot of life lessons? No financial interest in my talk. So what do we define, like how do we define as patient partnership? Like when I Googled this, couple of definitions were there. One which caught my attention is the knowledge of a patient develops the experience of health and psychological problems from the trajectory of care and services provided by us, and the impact of these problems on his personal life and that also of his relatives. So this is the one which was of quite significance. However, when we say patients as partners, why we need to think like this? All of us are very good clinicians. We take extra care of our patients. There is no doubt about it. But this COVID epidemic has taught us that we need to go beyond our comfort zone and take that extra step so that we can help our patients in his hour of crisis even in a better way. Basically, we are also looking at safeguarding ourselves as well as safeguarding patients, whether you are in private practice, in an institution practice, or a charitable wing. The screening, investigations, clinical care, and research for that matter has taken a complete 360-degree turn around the way we were delivering all this, care to the patients. We are all battling the COVID epidemic, and we are still battling the COVID epidemic, but we are also battling the economic, the psychological impact, and also the job losses it created not only in the other industries as well as in healthcare industry as well. So how do we look into all these parameters? And also on to our surprise, there is an increase in disease severity levels. You know, if you see ophthalmic diseases because of various other factors, especially the retinal diseases and the uveitic diseases, because of uncontrolled systemic status of the patient, there is a decrease in physical activity, stress levels are very high, and delay in getting timely care. I think this is one of the very important point of discussion as of now today. Just take example of one patient, a diabetic patient who has various comorbidities. You know, the comorbidities increase the patient's burden to other clinics as well as, you know, to the other systemic disorders as well. So we are not looking only at the retinal problem or a uveitic problem. We are also looking patient slightly beyond. And average visit by a DME patient, this was a published data which I took from PubMed, and what we see here is, you know, the retinal visits are of paramount importance here for the any patient, because they
Manoj, can it be a little louder than this? Little louder, yeah.
better now.
Yeah, better now.
Yeah, thank you.
Thank you.
So, coming to a retina specialist as well as diabetic and endocrine clinic visits are, you know, go hand in hand, and they are also of the same number of visits. However, at the same time in our OPDs, what has happened is, though the diseases are on a rise, you know, but the patient numbers are decreasing because of fear, anxiety, affordability, and the factors, they keep on multiplying. You know, they are going, the list is endless, but I've taken few of the factors which are common. The stress level has affected not only the patients, the healthcare providers, and we all of us are aware that we have recently lost one of our very dear colleague because of stress due to various other factors. So in a nutshell, I wanted to highlight this point is the stress is playing at a various levels. You know, it's not only financial stress, so there are a lot of other psychological stress which are depressing the patients as well to come to us. So what are the steps we have taken till now, and what are the things which we can do in future? As ophthalmic governing bodies, AIOS, VRSI, and USI have taken certain steps, and we were one of the first ones, rather Retina and Uvea department was one of the first ones to give consensus guideline managing this vitreoretinal Uvea practice in this current pandemic era, which was very appreciated. However, still a lot more has to be done on terms of awareness, the sanitization, though we are doing, but the accessibility of the care has to reach to the needy patients. The transformation, what we are looking in our approach to prevent these blinding diseases, which we encounter in routine practice, has to be taken to the grassroots level, and we have to come up with some more innovative ideas as to how we are going to, you know, see this healthcare system, which is a derivative of lot of hub and spoke type of models. You know, we have patient who is all of us are having a patient centric approach, but we need to involve the pharmacists, the specialists, the government, industry, physicians. There are so many factors which has to be really look into it, and slightly has to be involved in a better way. This picture particularly got my attention. You know, healthcare's 360-degree transformation. When we were small kids, we were, you know, looking to join the medical school. We used to see pictures in olden medical school books, you know, where the physician is going to a patient's home and taking history and giving the treatment. Nowadays, physician also has to reach a patient's home. You know, this is a patient who is sitting at home, but how you can reach it? We have to reach it digitally. So this is the transformation what we are looking at. You know, there will be a total transformation. Patients don't want to come to the hospital because of various other reasons. Even the accessibility is there. They want you to be available on the go. So these are the changes, whether you are in private practice or institutional practice, or for that matter, research as well. You need to incorporate in your practice. Otherwise, we will lose the bus. So these are the things, in a way, in any transformation, ultimately patients are the key, and they hold the center stage. Okay. Ophthalmic community per se, if you compare other specialties, have come out together and they have raised up to the challenge, and a lot of innovative ideas are already in place. However, we need to do something better than this, what we are doing. And now we know all these things, you know, how it has affected the ophthalmic practice and all. I'm not going to go in detail. Couple of data which have been published as well, which tells us that the diseases, blinding diseases like neovascular AMD or panuveitis or diabetic retinopathy, when these patients, especially the one-eyed patients who have not received the treatment, they have gone blind, or at least a severe amount of vision loss has been there. So how can we, you know, overcome this? A lot of media news also have been publicized. These are a couple of publications from the newspapers, where a group of our ophthalmologists have come to reach out the public via mass media, and even VRSI has done some campaigns. When we talk to our fellow colleagues, what we see in uveitic and retina practices, there is a rise in patients who are coming with panuveitis, mainly sight-threatening panuveitis, and also there is an increase in viral etiologies of panuveitis nowadays. PDR, DME, ischemic CRVO, and the list goes on. And especially we are seeing more and more central serous retinopathies. Patients who are particularly at risk are one-eyed patients with a lot of systemic comorbidities, COVID-19 complications, and some patients also have a fear of getting COVID-19 by visiting a hospital. So as we know, the ophthalmic clinic are also at risk. So we have taken all those precautions. So we'll not waste time on this particular topic, but the cost and treatment burden has also increased over a period of time. If you look at the recent statistics available, the time spent by an individual person in any specialty clinic has come down, but at the same time, the cost of that the multiple visits because of the pandemic and also various reasons have gone down or gone up, sorry, or by almost 2 to 3 times. So how do we confound for this, or how do we take care of this? We need to keep account of everything because there are so many job losses, pay cuts. So though the situation is improving, the economic situation is improving, but the patient's fear is always there in the mind, including the insurance sector, which has given us a big blow. A lot of treatment has to be covered in insurance segment as well. So multiple visitations in current pandemic are a big challenge, and we have to slightly come up with some more, kind of innovative ideas at every step. It can be therapeutic, it can be psychological, or whatever. The list goes on and on. So if you look at the cost of intravitreal injections, what a patient typically spend, because I've taken this because this is one of the most commonest thing what a patient spends in a particular retina clinic. So what you can see here, the numbers are in thousands and also denotes the number of injections what the patient has taken over a period of time. So the cost is quite exorbitant. However, if you compare alternative type of treatment where the patient requires, say, for example, anti-VEGF, but you want to shift to steroid, the cost comes down significantly. So these kind of permutations and combinations we have to think of to help our patients. How do we can engage patients? This is another question. We can surely engage our patients in different ways, but what do we understand by patient engagement? We were doing all these things, over a period of time. When patient calls for an appointment, we'll take a history, look at his systemic status and all those factors. But can we do something better than that? Yes, surely we can do something better than that, right from our healthcare technicians or your caregivers to pharmaceutical companies to healthcare institutions, and the list goes on and on. But based what I suggest is, or what my point of discussion here is, based on our individual practice pattern, whether we are in an institute or in a private practice, whatever routinely you're doing, you need to see or revisit the entire thing and do one step ahead, or go one step ahead and do something more, so that ultimately the patients get benefited, and also we don't lose our set of patients, and also give them the better care or timely care. So the patient engagement list goes from symptoms, diagnosis, decision, treatment. I don't have to tell all of us because we are quite competent clinicians. But at the same time, the patient engagement framework, we have to revisit this. That is the only point I want to highlight here. We have to revisit whatever we are doing till now as how another step we can take, and we give the benefits of patient engagement, ultimately leading to a patient experience, which the patient experience and also the treatment experience what a patient get will try to get the confidence back in the patients, and then again the same chain will establish. One patient will get another patients, and there are various places to engage. We don't have to enumerate. Based on individual practice, we can decide and try to think of the innovative strategies. Ultimately, all these things will lead to getting back the patients in our clinic, their health, improving their health conditions, and also safeguarding the healthcare professionals. There are various strategies, right from educating healthcare providers about patient engagement, supporting the patients to become actively involved, broadening the ways in which patients are involved, recognizing the importance of communities, needing what is the need of the community, and then take it forward, and then do something on the automated platform as well. In therapy situation, though there are certain long-acting agents which are available with us for the treatment front, but this is going to be a reality soon, like a mobile OCT, a home OCT, home-based OCT, or a mobile injection van. Patients who cannot come to the clinic, can we reach out to their places to give just intravitreal injection? This can become a reality if can when Shankar Netralaya can have a van who can go and do a cataract surgery in the villages. Why can't a van can go and give intravitreal injections to the needy patients? So all this becomes a reality. The recently Shroff Eye Hospital has launched a very good mobile outreach camp in which a lot of things have been incorporated, so and backed by digital solutions. Everything can be backed by AI based platform, mobile application. There are so many things which we can work on. I think Shankar Netrad and LVP are already one of the pioneers in doing all these things, ultimately setting up things which can come on a mobile app for every patient, and this becomes which are feature rich platforms and become a future for our standard of care. Why we need this is, we need, if we don't change with the technology will just leave us out. So we need to first of all come out of our comfort zone, try to adopt this technology and take it to the doorstep of the patient to give a patient better patient care. Can something has been done already? Yes, AIOS and also a couple of societies, especially the Royal College of Ophthalmologists from UK, have done a lot of work on teleconsultation already. There are a lot of protocols. These are all available online. You can just go and see how they have given step-by-step approaches, how you can go about it, what are the requirements, how you can incorporate in your daily practice. And this is all legal. There are consent forms, so it's not, nothing is illegal. There is all legal. The patient can pay you based on the paid platform, whatever you have incorporated. At the same time, very heartening work has been done by our group of people from Shankar Netralaya with Titan Eye Plus, where their entire model is based on the Titan Eye Plus centers across India. Basically, it's a one the thing what we are trying to highlight is
do I take care of my patients? I have patients from all across India who cannot travel to come at me and to send me urgent messages saying that they need an opinion. I have managed to use our hospital medical records to get some information about it, but without certain additional tests, I am actually handicapped in treating them to the best of clinical standards.
Kind of messages can be driven across. So the basic idea is the Titan Eye Care centers, almost they are there in all the tier 2, tier 3 cities. So they will be seeing patients with a consultation program with a diagnosis from Shankar Netralaya based Chennai. And then if needed, the patients, if they require advanced treatment, will be referred to our own alumni locally, or if at all required, then they can come to the tertiary hospitals like that. So the model is very good, very impressive, and already good number of patients have been enrolled in that. So we need to think something beyond this. We need to think something.
I know you are afraid coming to a hospital today. COVID times, lot of stress, but it has really caused lot of problem. Many patients who required regular eye care.
We will not go into the details of this video, but what this video is highlighting is just to get the patient confidence back, so that these patients can come to our own OPDs and our own clinics and get treated in time. The technology is always there. We need to think about future, how we are going to incorporate this artificial intelligence, big data, teleconsultation, AI. We are working, quite a good amount of work has been done from India as well. And how do we take this, Dr. R.R.N. sir has already published validation of this deep learning algorithm, and so on. The work is going on for last 5 to 7 years. We're very promising on AI platform. Whatever Sundar Pichai is talking to the entire world, most of the work has been done from India. So we are really proud of all this, but we need to go that extra step. So like a mobile device can be given to a patient, and all this kind of authentic photographies will become a reality soon. And then we can come over with this pandemic with a very strong confidence and reach the unreachable. So this is very important. We need to also go to a village level where the care is even not reached, and then try to do something better, whatever we are doing right now, a kind of a hub and spoke type of a model. So whatever I have spoken in a brief time, we need to incorporate technology in a big way to take care healthcare to doorstep of the patients and give a complete 360-degree turnaround. How we can achieve is we need to see our own whatever strength as of now, and we need to work on our strengths even further, and then we can take this further. So we need to gain the patient's confidence, make them more doctor friendly, get them as our partners again, and do the best whatever we are doing right now, and then do something more than that. Thank you very much for a patient hearing.
Thank you, Manoj. It was a very nice and elegant talk. One of the things which I have found that, there's a patient education is quite important. I used to think that how I will explain autoimmune uveitis to a patient. But I found that if you try, you can teach the patients every disease in its own term, if you can really try and think about it. And we need to be patient friendly, and the access of digital media and electronic media helps us all. And we should be on the high pedestal. We should not be on the high pedestal. We have to really come down and to be on the patient's level. That's one of the things which I learned from experience.
Absolutely. I think it's a beautiful presentation by Manoj. And Manoj is very, very nice, exhaustive. And it was a 360-degree coverage, in my opinion. And very good coverage of all, how we can combine. Whatever you have been practicing is the techniques, but you need to combine the technology. Combine the technology with the technique, and that's what we have to do. And COVID has opened up a new vista for all of us, in the sense that we can do a lot of introspection, we have time, we can do a lot of lateral thinking, and that's what we are, all these innovations have come out in this COVID era because of this, and how artificial intelligence and technology, and none other than Rajiv Raman is there, who is a father of artificial intelligence, I would say. Rajiv, you have anything to add?
No, I think what Dr. Manoj has told is absolutely correct. These are challenging times, and we need to really keep our patience and follow all the precautions. Difficult to break the barrier at this stage, because the biggest worry as far as patients are concerned is the coming to a hospital. That's the biggest worry they have. Even at home, we don't want our parents to go to a hospital now. And I think important is it's important to show concern to them, and those who really need care, we should try to motivate them to come to a hospital.
Absolutely. I think it's very important. And Rajiv, your video on the COVID awareness, and it is really good, Rajiv, and I have circulated it to all the groups. It is very, very useful. Thank you very much for that.
Thank you, sir.
I also welcome, take this opportunity welcoming Professor Shobha Shivaprasad, who has joined us. Thank you very much, madam, for joining us all the way from UK and London, Moorfields Eye Hospital. I know you are going to give us we're looking forward to your keynote address as well. JB, we go on to the Uvea session. JB?
You are muted, sir.
So we'll start with the Uvea cases. We have chosen we will start with the Uvea cases, and the first case will be presented by Priyanksha. We have got a great panelist over here, and they are expert in the uveitis cases, and they have got good experience. I think they can discuss about the each case, and I did not really make any comments.
We want your comments also, JB, please.
Yeah, okay. Yes, okay. First case is Priyanksha.
Yes. Over to Priyanksha.
Priyanksha, please.
Please unmute yourself and start.
Good evening, everyone. I thank JB sir to give me this opportunity to speak in this wonderful webinar. I'll be speaking on optic neuropathy and Uveitis syndrome.
You have to click on the slide.
Click on the down arrow on your computer. Otherwise, there will be a small arrow on the left bottom.
Yes. Yeah.
There will be a small arrow. You can click on that as well. On the left bottom of your screen.
Yeah, it's coming now.
Okay.
So the first case is of a 43-year-old male patient who came with gradually progressive painless diminution of vision in his right eye since 25 days and his left eye since 15 days. His past and systemic history were non-contributory, and there was no history of TB or TB contacts. On examination, his visual acuity was 4/60, improving to 6/60. There was gross RAPD. The anterior segment in the right eye was within normal limits. There were few cells in the anterior vitreous face. The right eye fundus showed a clear media with a florid disc edema with peripapillary disc hemorrhages and few hard exudates. There were multiple SRF pockets with turgescent veins.
Next slide. Yes.
In the left eye, the visual acuity was 6/36, improving to 6/12, and the intraocular pressures were within normal limits. The media was clear. The disc margins were distinct, and one can appreciate the retinochoroidal folds with few SRF pockets. So this is the fundus photo montage of both the eyes, showing the disc edema with peripapillary hemorrhages in the right eye, multiple SRF pockets in the right eye, along with inferior exudative detachment. In the left eye, one can see a relatively normal disc with multiple SRF pockets. So this is the OCT picture of the right eye, showing SRF in right eye with the RP undulations and few septae. A similar picture is seen in the left eye with RP undulations and SRF. Though the height of the SRF is lesser in the left eye. The FFA shows a normal arm to retina time with pinpoint leaks at the level of the RPE. There were some dark lines due to the RC elevations, the choroidal folds, and one can see prominent telangiectasia involving the disc with blocked fluorescence due to the hemorrhages. There is some staining of the veins around the disc. The typical placoid pooling, however, cannot be really appreciated. There is profound leakage of the disc in the late phases. In the left eye, similar picture is seen. Pinpoint leaks at the level of the RP is seen, and multiple hyperfluorescent lesions are seen, will become more prominent in the later phases of the angiogram. There is disc leaking and staining and leakage in the later frames. When we investigated him, his CBC was within normal limits, ESR was normal. Basically, all the investigations were within normal limits, except MAN2 was positive with 22 in duration. So we diagnosed the patient as probably weak age and started the patient on intravenous dexamethasone, 200 milligram and 5% dextrose. And subsequently, he was continued on oral steroids and tablet azathioprine 50 milligram TDS. So these are the subsequent OCTs, sequential OCTs during 3 days of admission. After a week of follow-up, we see that there is some resolution of the disc edema and the hemorrhages and resolution of the SRF pockets, especially in the right eye, and the vision has improved to 624. The intraocular pressures in both eyes are within normal limits, and we start to see some pigmentary changes which have started to appear nasal to the disc. The left eye, there is a marked improvement in this resolution. There's marked resolution of the SRF pockets. So this is the OCT corresponding to this visit, and we can see that the RP undulations have reduced markedly, and so has the height of the SRF in the right and left eye. There is almost normal like resolution of the foveal counter. So he was put on slowly tapered steroids and tablet azathioprine, and following a month's time, His vision improved in the right eye to 6-9 parts, the resolution of disc edema, and one can now appreciate the RP pigmentary changes which have developed almost all over the fundus, and also one can note an area of focal phlebitis in the right eye along the supratemporal arcade. The left eye, the disc appears normal, and there's some pigmentary changes, especially inferior and temporal to the fovea. This is the fundus photo montage, and one can appreciate the pigmentary changes which has developed along with resolution of the disc edema in the right eye. This is the fundus photo, fundus autofluorescence picture showing this very dramatic hyperautofluorescence in both eyes, and it seems to be emanating from the disc in both eyes in a rather reticulate sort of a pattern. And these are the corresponding OCT pictures showing this resolution of resolving SRF and the heaped up RP, which may signify subretinal fibrosis setting in. And if we see the OCT sections on the right bottom, one can see disruption of the outer retinal layers and loss of ellipsoid zone. The left eye, there is the normal foveal counter has been restored with the disruption of the ISOS junction. So this is the final follow-up at like the third month. The vision has improved to 6.6 in the right eye, and in the left eye about 6.9. And to summarize, these are the OCTs at various points of time depicting the resolution of the SRF and the RP undulations on treatment and improvement in vision. These are the pictures of the left eye. So our diagnosis was probable leakage with right eye query NAI1. I have written query because visual fields were not done to show the field effects. There is another case which I've come across. This was of a 42-year-old male who presented with diminution of vision in his left eye since 1 month. There were history of episodes of pain, redness in his left eye, which were treated locally with some eye drops. And there was some alleviation of symptoms with the eye drops. He had complaints of frontal headache for 3 to 4 days. But the important thing is that he gave history of hypopigmented skin patches since about 1.5 years and newer patches since 1 year, signifying chronicity of the disease. So the right eye clinically looked almost normal. There was mild hyperemia of the disc and some deep retinal deep retinal hypopigmented lesions. And SRF actually cannot be appreciated in the right eye clinically. In the left eye, there was mild medial haze, and the disc was pale. There were hypopigmented RP alterations around the disc with the bullous exudative retinal detachment. There were prominent blot hemorrhages, deep retinal hemorrhages temporal to fovea, inferior to fovea. So on systemic examination on his extremities, he had these vitiligo patches on the dorsum of his toes and hands. So this is the OCT picture showing the SRF in the right eye and the RP bumps in the right eye. And the left eye shows almost total loss of the outer retinal layers with atrophic retina. This is the FFA picture of the right eye showing these hyperfluorescent dots supratemporal, superior and supranasal to the fovea, along with late staining and leakage from the disc. The left eye doesn't show much. There are window defects because of extensive, because of the thinning of the retina. So in this case also, the investigations were essentially normal. The BP was normal. The B scan was done, which showed no evidence of mass lesion or T sign. And our diagnosis was incomplete Piquet syndrome with left eye chronic exudative RD and optic atrophy. So again, this patient was treated with IV dexamethasone 200 milligrams, and one can appreciate the resolution of the subretinal fluid after 5 days of intravenous dexamethasone. So I would like to thank my colleagues and my all my colleagues here, and especially Dr. Alok Sen, our head, for their encouragement and all the support. So coming to the discussion.
Discussion part of it, Priyanksha,
Yeah.
will
Yes, sir.
keep for the
Panelists.
panelists. So I just wanted to make one comment is here that it's not AIUN, is the VKH itself can have disc edema with disc hemorrhage. Number 1 point. Number 2 is that you can use the intravenous methylprednisolone instead of dexamethasone, which is better than dexamethasone.
Yes,
Okay.
sir, that is true. But in this instance, the type of strata of patients coming, they come from lower socioeconomic status. So even though we have been trained to give intravenous methylprednisolone, it is a norm here to give IV dexamethasone, which is equally effective because of financial constraints, sir.
So you have got 2 success story. I just like to now invite the panelists, one after the other, to talk about that one, to comment on the panelists. Over to the panelists.
Yeah, Priyansha can stop sharing the screen.
Stop sharing the screen.
Yeah, so that we can go to the panelists.
Can I start?
Yes.
Yeah, very nice case, Priyansha. I think both the cases were nice and different clinical presentations. I think the first case was more of a Harada's disease rather than the VKH. And just a point of observation that I do in my clinic. We all know that a lot of people use ICG a lot, not to diagnose, but also to monitor. And most of us clinicians do not have the ICG. So I personally use the feature of the enhanced depth imaging, which is the EDI imaging of the choroid. And this is, I have found personally a very useful tool, not only to diagnose, but to monitor the treatment. And we have already presented a paper last year in the academy where we have shown that there is a recurrence in increase in thickness of the choroid even before the patient complains of any symptoms on recurrence. So I think that's a very, very important marker. And I put all my patients of VKH on a very strict follow-up protocol for the EDI OCT monitoring. And just the third point, I think in your case, if you see, I think it was a very nice diagnosis. If you see the changes, they look, and you have to differentiate when you see these old patients. You might have patients coming to you who have been treated not properly, but half treatment taken. And sometimes you get a mixed picture of serpiginous choroiditis looking like picture, but actually it's a VKH. So these are just a few of my comments.
Rajiv and myself has done a Swepsos OCT in VKH, serial Swepsos OCT, and that was published in Ocular Immunology and Inflammation, showing that utility, as Dr. Ola is telling us, that we showed that this is quite helpful. Others to comment, please.
The other panelists can.
I think. Can I say? I'm just curious to know, what was the dose of dexamethasone you used?
200 milligram. 200 milligram for 3 days.
Isn't that a little on the higher side? Because even in patients with septic shock, we don't use more than 10 milligrams. The highest dose is 1 to 6 milligrams per kilogram body weight.
So this is the dosage we use routinely, sir. Every other day, so many patients get admitted, and they do pretty well. We do the
I agree.
Yes, sir.
No, I do not deny that they did very well, but
yes, sir.
So the dexamethasone vial is 2 milligrams per ml.
Yeah,
exactly.
I think there is some error. I think it should be 2 milligrams rather than 200 milligrams.
No. Yeah, you are correct. She is correct.
Yeah, the vial.
The highest dose, even in a hospital, if you use, nobody exceeds more than 4 to 6 milligrams per kilogram body weight.
Yeah, you are correct, Shali.
So there is a question actually posted by Dr. Giridhar to Dr. Ale. And that is that you just mentioned that there is an increased thickness on EDI OCT, Dr. Ale, even before the patient becomes symptomatic. So would you restart the treatment even if the patient is not symptomatic?
Yeah, that's exactly what I've started doing now. I mean, I've burnt my hands initially when we were trying to prospectively see these patients and just trying to learn how the EDI changes. And we were seeing those increased choroidal thickness coming back. But I used to held on treating these patients unless and until they come with visual complaints. But now it's almost, I'm very much convinced that sooner or later, once you have these EDI changes, they are going to have problems. So I either, pump up the steroids or add steroids to the already, if the patient is already on any immunosuppressives.
And I think
sometimes if it's a unilateral disease, I also do local treatments if addition of a systemic therapy is contraindicated. And I personally have used Ozurdex quite a lot in many of these young patients who have unilateral recurrences of VKH, who are not very, happy taking systemic medications.
And I think another important thing would be, Dr. Rale, hopefully I think you'll agree that when we are monitoring the choroidal thickness, I think that's another important way of monitoring when to stop the steroids, because that is going to be telling us that there is a persistent inflammation which is going on, and probably it's too early to stop the steroids.
Yes, I agree with Manisha. I agree.
We all agree on this.
Sushil wanted to say something. Sushil.
Yeah, I just say that, choroiditis and retinochoroiditis, we are following up on autofluorescence. But in VKH, there's hardly any changes in autofluorescence. So EDI SS OCT thickness remains the best biomarker for monitoring VKH. And just one small comment, I thought that the second case, Dr. Priyanshi, there was an infratemporal BRVO with retinal hemorrhages in the inferior infratemporal quadrant. Would you like to make a comment on that? With a notching inferiorly of the disc?
Could be, sir. I'm not sure why there were hemorrhages. Recently, one of our colleagues, Shaukat, he has published the case report, I think a letter to editor in ocular inflammation, that acute VKH with bilateral hemorrhages, and they have investigated a very unique presentation of VKH where the patient had deep retinal hemorrhages in both his eyes, and with the resolution of the exudative retinal detachments, there was also resolution of the hemorrhages. I just put across the case. They might have been an ITBRVO. I don't know what is the cause of the hemorrhage.
Angio is also not showing filling of the vessel. If you go through it and maybe at the end of the Uvea capsule, you can show us the color photo and the FA, you will see that there is a BRVO in the infratemporal quadrant left eye.
I just wanted to add
I don't know what was the cause of this pallor. There's no history of trauma, and we often see, because this a lot of surrounding village areas, so not of neglected cases, especially in the times of COVID. So usually, like, even the chronic exudative RDs, they don't have like optic atrophy. I mean, PL negative eyes, they may be having like a vision of 1 or 2 meters, but PL negative is rather, I thought it was interesting.
Okay, we'll move to the next case.
Next presenter. Make sure the JB, the presentation is only 5 minutes.
JB, so I just request everybody to present only that clinical features, and the rest of the discussion will be done by the panelists. Risha, please.
Yeah. Good evening, everyone. At the outset, I would like to thank Dr. Biswas for giving me this wonderful opportunity. And mine is a case of regarding challenges of choroiditis management in a pregnant lady. 22-year-old lady who was 7 months pregnant presented on August 1st with complaints of defective vision in right eye of 2 weeks duration. In the past history, there was no history of similar episodes in the same or other eye before. And regarding vision, best corrected visual acuity in right eye was 6/9 and left eye was within normal limit with 6/6 vision. Anterior segment examination, right eye, there was circumcorneal congestion with grade 1 or grade 2 cells. Fundus examination, right eye, there was grade 1 vitritis, margins were blurred with disc edema. In the posterior pole, temporal to macula, there was a choroiditis patch of around 1 disc diameter with adjacent exudation and fluid detachment. OCT showed fluid detachment and RPE elevation corresponding to the area of choroiditis. Left eye was within normal limits. On asking repeatedly, she gave history of pulmonary tuberculosis for mother around 1 year before, treated for 9 months, and history of pulmonary TB for sister 6 months before, treated for 6 months. Manjo was done, which was 20 in 20 in duration with raised ESR of 48 millimeter. Rest of the blood investigations were within normal limits. HRCT was not done since she was pregnant, and pulmonology evaluation was done with sputum AFB, ruled out pulmonary tuberculosis. She was started on ATT under RNTCP regimen. There was no fitness from the obstetrician for systemic steroids. After 1 week of ATT, she came with more defective vision. Vision dropped from 6.9 to 6.36. The choroiditis lesion size increased with more of exudation and more fluid detachment. But there was no fitness from the obstetrician for steroid. We told her to continue ATT, and she came after 3 weeks with better vision of 6.24. The lesion was resolving well, but there was disc edema. At the same visit, she gave a history of anorexia, vomiting, tiredness, constipation, and she came with her LFT levels. Serum bilirubin was too high, 10. SGOT, SGPT was elevated. Serum creatinine was normal, and the BP was 160, 90 millimeters of mercury, and she had pedal edema also. Luckily, we had not given systemic steroids. An emergency pulmonology and gynec evaluation was done. She was diagnosed as drug-induced liver injury with PIH. Emergency cesarean section was done the next day. 1 week post-op, her BP was normal. Serum bilirubin, ATT was also stopped immediately, and BP also became normal in 1 week time. Serum bilirubin from 10 reduced to 1.5. Again, modified ATT was started to drug challenge doses. Initially, ethambutol and pyrazinamide was started, and after 2 weeks of modified ATT, her vision was more better. Vision improved to 6/18. Choroiditis lesion was almost resolved. OCT showed resolution of fluid detachment also. So since it's an extrapulmonary tuberculosis with only ocular involvement, so how long we should continue ATT? I mean modified ATT, and is there any role for systemic steroids now in the postpartum period, or will it increase the liver injury more? There is no active choroiditis lesion now, so should I continue modified ATT for 6 or 9 months without steroid, or is there any role for intraocular steroids? I want opinion.
Excellent presentation, Risha. I would like to ask the panelists' opinions. To start with, Shalil, can you tell some? Can you shed light on that? How to approach? Shalil,
the
please.
Clinical photograph is very, very suggestive of choroidal tubercle. Extremely suggestive.
Yes,
along with the positive Manto, and this is definitely a choroidal tubercle.
And it responded well with the ATT also.
It responds well, but initially you had probably a paradoxical reaction, and then once you delivered and you gave steroid, it has settled very well. There are a few points. Just because patient is pregnant does not mean that you can't evaluate the chest actually. You could have got an MRI of the chest done. That is safe in pregnancy. I mean, that's what they say. So that is one option you can do.
I think X-ray was done with some precautions. And
chest X-ray is totally useless. Please don't do chest X-ray ever in any patient for any reason whatsoever. If you pregnant women, you can do MRI of the chest. It gives you a fantastic amount of information, and it's quite safe actually. The question is, how long should you use ATT for? Nobody has ever done a proper trial to tell you that answer.
Pulmonology says it's according to the clinical response from ophthalmology side, and it's already only 2 months now with ATT.
So some people say give for 6 months, some people say give for 9 months. But I think the general consensus among uveitis specialists in India is that we give for 9 months. And one helpful tip that I have found is if you do an abdominal ultrasound for many of these patients before you start ATT, and if you look for signs of fatty liver, especially higher grades of fatty liver, which unfortunately a very large number of people have, that is a potential biomarker of developing hepatotoxicity because of ATT. So in that case, you can either reduce the dose a little bit in consultation with your GI friend, or you can get it monitored, SGOT, SGPT, at a more frequent intervals.
So I think, Salil, I have a comment and a question both. I mean, Professor Gupta has taught us that you should never use ATT alone, always start steroids because
Always
of the fear of paradox. Now, this is a different scenario. So she's a pregnant lady. Maybe there were reasons why she was contraindicated for steroids. But is there any role for local steroids like Ozurdex, along with ATT?
Not only Ozurdex, you can even use, people have used Ozurdex, people have used anti-VEGFs, people have used triamcinolone. So anti-VEGF or Ozurdex is a great idea.
Ozurdex is more appropriate because this session is being sponsored by Allergan.
You are being recorded, Rajan.
No, right. No, I am saying this because I had a similar case scenario, and I was not sure, but the only option left was Ozurdex, and we've had 3 cases, same pregnant ladies, contraindicated, and we had to start ATT with Ozurdex, and she responded very well.
All of them have responded extremely well.
I think it probably helps to reduce the sequelae, the pigmentation, depigmentation from the choroidal tubercles.
Correct.
I have a comment. Can I?
Yeah, Shishir, can we ask?
Yeah.
Dr. Avinash, he had a comment. Let him make it and then we'll shift to you. I think Dr. JB had to shift to another meeting, so I'll just be helping.
Manisha, you take over in that.
Yeah. Yeah,
Just
Dr.
a point
Avinash.
to make, yeah, because when you look at a patient who is pregnant and comes in with a unifocal choroiditis, so 2 common things which come to our mind is whether it's going to be tuberculosis or sarcoidosis. These are 2 important differentials which come. Now, considering the point that the patient is in the 3rd trimester and the serum cortisol levels are pretty high in the pregnancy state, it's very hard to find an autoimmune condition. So that is one of the ways by which you can probably rule out to a certain extent, or you keep that as an autoimmune disorder at the backseat of your mind. So primarily you're looking at an infectious etiology, something which you have to consider. So I'm just telling you in terms of ease in which the working diagnosis could be made and the proceedings could go on. And if the diagnosis has been tuberculosis, like the one you had presented, and the patient goes to have an ATT being administered. So the question lies, because these patients, though rare, to have a tuberculosis in pulmonary in pregnancy, and that too coming to an ophthalmologist, that's not very common. The issue is, if you have to have the discussion with the pulmonologist, even in pregnancy, they don't have that much of experience, or not many patients get treated. But irrespective of the trimester, they have to have the treatment ATT being done. That's something which is important. At the same point, one has to understand that liver toxicity is something which we have to be monitored at a weekly basis, especially at nearly when the patient is coming to the 3rd trimester. So weekly evaluation of liver function enzymes or liver enzymes is something which is very important. And if liver does get affected in terms of the enzyme levels, so you have those 3 drugs which are more notorious to have this liver toxicity. The topmost among them is rifampicin. Then you have the INH and the pyrazinamide. So it can be all 3, or it can be one of those. So it's a little bit a tricky situation, which one has to let go to have the rest of the treatment go on, because you can't let go 3 of them all at a time and to get the response what we need, especially when the liver toxicity is already set in. So that's a challenge which is there. So with the pulmonologist will take care. The duration would be as similar to the duration of ATT would be similar to an extraocular or extrapulmonary duration. It will be a minimum of 9 months duration. And the 3rd question is whether you have to do steroids. So one need not have to do steroids all the time in a case of tuberculosis. So sometimes with ATT, the response can be so dramatic and phenomenal. Even in a week or two, sometimes the choroiditis can just flatten out. So especially in pregnancy, when you have, again, the cortisol, take the advantage of it unless and until it's really required. So we can avoid a possible steroid as much as possible unless and until it's really required.
Dr. Shishir?
No, I just was saying that there are two more things to consider in this scenario. Is that on the OCT, you see a very large neurosensory detachment. So there is an element of exudation that is there even before you started the anti-tubercular treatment. And the second is that some of the disc changes may be because of the hypertension that she is having along with it. So, you know, there are 2 or 3 things to interpret here. That's why there has been a dramatic response to just anti-tubercular treatment. Otherwise, if you have a paradoxical reaction, you do require some form of steroid to control the condition.
Before starting ATT, BP was normal, and the other eye disc was also normal.
Yeah.
So I think, Risha, basically the take home from your case would be that if you're in such a scenario where systemic steroids, you're not getting a clearance, you can opt for local therapy along with ATT. That's what the recommendation is, that you can opt for Ozurdex. And you can, we've also, there are a lot of reports where you have these tubercles responding very well to anti-VEGFs also. Topical, where you have the tubercles just melting away. Of course, again, for that, again, in a pregnancy situation, you may require a clearance to be taken.
Yeah, madam. In the 1 week visit, because of the paradoxical worsening, I was little worried whether it's whether the diagnosis is wrong or not. So I was waiting for 1 more week.
Right. Thank you, Risha. Thank you so much. We'll move on to the next case.
Yeah.
So we'll have the next case by Dr. Vijay Tomar.
Guru Brahma, Guru Vishnu, Guru Devo Maheshwara, Guru Sakshat Parabrahma, Tasmai Shri Guruve Namah. So my sincere pranam to all the teachers of Shankar Netralaya who ignited that flare inside me to see the flare and cells inside the anterior chamber and the vitreous. The teachers who taught me the real meaning of ophthalmology. So good evening, everybody. And I am presenting an interesting case of pediatric panuveitis. It's a 14-year-old girl who was a resident of Lakhimpur, a suburban area, presented to the hospital with the history of blurring of vision in both the eyes for 2 weeks. This blurring of vision started in the left eye, followed by the right eye, and this was sudden in the onset. It was painless and progressive in nature, and there was no history of cough, headache, trauma, any joint pain, backache, oral or genital ulcer. There was a past history of typhoid fever 1 month back, and there was no any other significant past history. Family history was insignificant. There was a history of contact with the dog and the cattle. And for his initial problems, this girl was treated with tablet cotrimoxazole, BID, along with the tablet azithromycin. And later on, she was shifted to tablet acyclovir 800 milligram 5 times a day and tablet prednisolone 40 milligram along with ranitidine for last 1 week. On ocular evaluation, the uncorrected visual acuity was 1/60 N36 and 3/60 N36 in the right and left eye respectively. And retinoscopy cannot be done because of the poor fundal glow. Intraocular pressure in both the eye were within the normal limits. Ocular adnexal evaluation was within the normal limits. Anterior segment slit lamp biomicroscopy was within the normal limit except the presence of flare and cells of grade 1+ in both the eyes. On fundus evaluation of the right eye, the media was very hazy. The disc was very hazily seen and some choroidal active lesions were noted along the posterior pole and along the inferotemporal arcade. This vitreous haze was little less in the left eye. The disc was found to be hyperemic. The choroidal exudation at the posterior pole and the inferior temporal arcade was also present in the left eye. And this type of lesions were also noted in the periphery of both the eyes. So the patient was advised for the investigations. The red blood cell count and total leukocyte count were within the normal limits, but platelets were 80,000 per cubic millimeter. On the differential leukocyte count, all the parameters were within the normal limits, but eosinophil counts were very high, that is 30%. ESR was 8 millimeter in the first hour. MAN2 test was found to be negative. VDRL was non-reactive. ELISA for HIV 1 and 2 was negative. Serum ACE titers were higher, on the higher side. RA factor was negative. And IgG for herpes simplex virus 1 and 2 along with the toxoplasma were found to be positive. X-ray chest peer view and CCT chest were normal. So the imaging modalities were used since the media was very hazy in the right eye, and the vitreous echoes along with the increased retinochoroidal thickness was noted. The patient was advised for the fundus fluorescent angiography, but since the media was very hazy or very little information was gathered, but in the middle and the late pictures of the left eye, incomplete ring of fire-like appearance in the inferotemporal aspect was noted along with a little bit CNP areas. So this thing was a little bit tricky, that investigations are not leading me anywhere. I was thinking that whether I am missing something or not. Then I revisited the history and I asked my patient further more questions. And at that time I found that there was the history of presence of ingestion of unboiled milk and pain abdomen. So I asked my patient to go for the ultrasound abdomen, and on the ultrasound abdomen, the reports were suggestive of ileocecal tuberculosis. So I referred that patient to the pediatrician, and the pediatrician started ATT. After starting ATT, after 3 days, the patient was put on the oral prednisolone, and after 4 weeks of ATT and steroids, this was the final picture. Patient's vision in the right eye was 612 and the left eye it was 6/9.
Beautiful.
Thank you.
Very nice. Very nice, Vijay.
Dr. Shishir, would you like to start the discussion?
Dr. Tomar, excellently, you have tried everything in your hands to do, but I don't know whether you would go with a diagnosis of, if we are talking of tuberculosis, what kind of tuberculosis are we talking? Are we talking of retinal vasculitis? Are we talking of choroiditis? Because I don't know, I thought that there was possibly a fungal infection or some metastatic end of kind of a picture, because once the condition is resolved, what on the angiogram when you saw that area, what is the area looking like? Is there a choroidal tubercle there where you had the ring of fire appearance now that you had a very clear media, or is it all gone? Then it,
Sir, it was a choroidal tubercle actually, and when the patient came to me, the patient was already given all the trials of that Bactrim DS and azithromycin, and later on somewhere else she was also treated by acyclovir for ARN.
Dr. Tomar, I just want to highlight one thing, that I was just reviewing the literature based on your case, and it was very interesting. If you can go back and see in clinical ophthalmology in 2014, there is exactly a similar case which has been reported. And in that particular case, it is a bilateral endogenous candida endogenous endophthalmitis with a mixed bacterial infection also. And there also the patient had a toxo titer positive. The patient who had a viral titer positive was treated with both the things, but the lesions kept expanding. And if you see in your case also, bilaterally you have these multiple yellowish white subretinal lesions. And the retinochoroidal thickening also what you are seeing. So if we see a typical fungal endoff, it usually has a vertical spread where you have these initial fungemia which takes place in the choroid, and it then involves the retina and then goes straight into the vitreous, causing a lot of vitreous opacification. So in your case, I totally agree with Dr. Shishir that my first differential diagnosis would be a fungal endoff in your case. Especially, I wanted to know that has there been any history of hospitalization or IV infusions in your patient, especially because there was a history of typhoid being given by you?
No, ma'am, there was no history of IV infusion. That kid was treated with the oral tablets only for that typhoid.
Manisha, where is the primary, if suppose a fungal and metastatic fungal endophthalmitis?
Sir, this can be just a hematogenous spread secondary to any kind of the IV infusion or these catheters, what you have in
Yeah,
place.
that is usually in dialysis patients. In fact,
Right.
recently, about a week back, we had a patient with a very bad endogenous endophthalmitis in a dialysis patient who got infected, and she became all right.
And these days, sir, after COVID, we are getting a lot of patients again of fungal endogenous endoff because they are on oral steroids. They are being put on long-term IV infusions also. So we are recently having a total spurt of these endogenous fungal endoffs. So I would have been, I was just wondering, because if you, there's nothing very much suggestive of a tubercular lesion in these eyes. I'm also very suspicious that probably are we missing upon a fungal endoff, and especially an infection like Candida. It has been reported that sometimes it can have a spontaneous resolution also. I don't know what is the take of other Dr. Ale and Dr.
Let's have the opinion of Ale and Salil.
I think I totally agree with you, Manisha, but the way it has responded, even I thought this is a typical fungal. But if you see the response, I mean, that's very dramatic. So, you know, it.
But the
there was the history that once the patient was treated with that banned DS and along with the steroids, the vision of the patient deteriorated.
So no, that's right. But so toxo was ruled out. But what about fungal? I mean, yeah. I mean, ultimately, the last slide that you show, there was a response.
Yeah.
So how if it was? I mean, if what we are thinking is fungal, why would it give a response to ATT?
ATT, and that ileocecal thickening was also there on the ultrasound.
Yeah, that might be a coincidental finding. You know, patient might have a systemic tuberculosis, and that itself puts him at a risk of fungal infections anyway. But as you know, Shishir and Manisha said, looking at the clinical picture, I think our first diagnosis would be very much fungal.
Initially, I suspected that it's an endogenous endoff. Second thing, I was suspecting that it can be a case of pediatric sarcoidosis, late onset. Third one, I was thinking that it can be a case of toxoplasma, but since it was a bilateral presentation with multifocal lesions, so it cannot be a case of toxoplasma, because toxoplasma bilateral is very rare, and with this type of picture, it is very multifocal lesions and bilateral toxoplasma. It's a highly uncommon presentation.
But Dr. Tomar, if you see the healing of the lesions also, it's not very typical of a tubercular lesion. You would get a lot of scarring and pigmentation, while here,
Salil has to say on this.
the way they have healed doesn't look very typical tubercular to me somehow.
But the patient responded to
dramatic recovery with ATT and steroids.
Yeah.
What else can you think of, Manisha? I'm just wondering. Because of dramatic recovery, no. If it's fungal, why should it recover with the ATT and steroids?
Yep, that's my point.
That is the only thing, sir.
Avinash, anything? Any expert comments, Avinash?
No, the working diagnosis would be endogenous only in terms of how we need to go about. And having spoken about endogenous, I just want to reiterate a point. We recently published a paper. Unlike the West, in Indian subcontinent, most of the endogenous infections, people do not have septicemia. It's a transient bacteremia or fungemia is what they affect. So unlike the West, patients walk in here with endogenous infections. It's not like that in the West where people are admitted. So that's history. What we conventionally read from the books cannot be applied here. So in this country, and I rightly agree with what Dr. Tomar said. If it's going to be toxoplasmosis, something not possible, because bilateral should look more common in immunocompromised patients, and they have extensive horizontal spread. So that is something which is not possible in this. In terms of very good clinical acumen, I would say ruling out of toxoplasmosis is on clinical evaluation very high. So again, endogenous, whether it's going to be bacterial or fungal, what would be on my radar, but lucky he found tuberculosis and it got resolved with tuberculosis. But if it's fungus, it would never resolve with that too. With steroids, impossible. No way it is going to do resolution with steroids.
And I put my diagnosis as tuberculous panuveitis because I was also suspecting it can be a tuberculous endoff.
Yeah, there is tuberculous endoff as well, but I think you got the better. No, we are all got the better of hindsight. So,
any CT scan chest has been done, Vijay?
Yeah, sir. CT scan chest was normal.
Normal.
Yeah.
Okay.
And this taught me a lesson. And after 6 months or 8 months, I saw a patient of Ease disease where, retinal vasculitis, where I tried my best to pinpoint that where the lesion is. And again, what I found, it was an intestinal tuberculosis which was causing the problem. And I discussed this with JB, sir. So one thing I taught with these two cases actually, that while we are suspecting tuberculosis, don't forget to evaluate the abdomen, because in the northern India, there is a tendency to drink that raw milk, and a source of Mycobacterium tuberculosis.
I think the point what you're trying to make is understanding the local geographic domain is very important. What might be applicable in your state may not be equal to the entire North India perspective. So it might be very limited to your place where you practice, but that's very important. Whoever comes into practice should understand the local area and how things go about in it. So it's very important for uveitis practice as well.
So thank you, Dr. Vijay. We'll move on to the next case. Dr. Amit, please.
Yes, ma'am. Is my screen visible, ma'am?
Yes.
Yeah.
Good. All right. A very good evening to all. I'm Dr. Amit Palkon, practicing Retina and Uveitis at Retina Specialty Hospital, Indore. I have no financial interest or relationships to disclose with this presentation. So a young lady, 23-year-old, she presented to us with diminution of vision in the left eye for 1 week. Her best corrected visual acuity was counting finger close to face in both the eyes. Intraocular pressures were normal in both the eyes. The right eye was quiet, but the left eye had 3+ cells in the anterior chamber and 4+ cells in the anterior vitreous face. The fundus examination revealed a disc edema, subretinal abscess, chorioretinitis, and retinal vasculitis. The OCT showed a huge bump with retinal inflammation. The right eye was showed a healed choroiditis with posterior pole chorioretinal atrophy and scarring. So we revisited the history, and there was no history of fever and altered sensorium, no skin rash, nodules, no joint swelling or pain, no genital ulcers. She had no history of any septic foci or any history of systemic immunosuppression. She also denied history of tuberculosis or a contact. So we went ahead and did a fluorescent angiography, which showed an early block with late leakage in the left eye, and as expected, a large transmission defect in the right eye. So to attain the decision heuristics for the left eye, we had to answer 3 questions. The first one was to locate the uveitis. So this was definitely a panuveitis. The second was whether the uveitis was infective or non-infective. So she had a 5 centimeter induration on the forearm with nodular opicities and the chest X-ray. So this had to be infective. The rest of the labs were within normal limits with a little lymphocytosis. She had a non-reactive HIV and VDRL. The third question was whether the uveitis was vision threatening and non-vision threatening. With the disc and macula being involved, this was definitely vision threatening. So the plan was to treat the cause with anti-tubercular treatment under the chest physician care, and to treat the inflammation with intravenous methylprednisolone followed by oral corticosteroids. It is here where we changed our decision, and we replaced the intravenous methylprednisolone with suprachoroidal triamcinolone acetonide, 0.05 ml given with a 30 gauge needle. At 1 week, we had a significant improvement in the exudation. And at 1 month, the disc edema almost resolved with decrease in the exudation, unmasking the choroiditis beneath it. The visual acuity, however, was 1/60. Intraocular pressure was maintained at 12 millimeters of mercury. The OCT showed some kind of subretinal hyperreflective material at the fovea. We started with exudative RD in the left eye, which actually significantly improved on the OCT. So if we compare suprachoroidal triamcinolone acetonide, which we call as SCTA, with intravenous methylprednisolone, the drug, there's 100% drug availability at the site of inflammation. It is equally potent if we compare to hydrocortisone. It has local action with no systemic immunosuppression. And the best point is it requires no referral to a physician for intravenous methylprednisolone. This is a short experience which we have at Retina Specialty Hospital. So we had 7 patients with 9 eyes, patients with indications of retinal vasculitis. These were all presumed ocular tuberculosis, panuveitis, serpigens like choroiditis, and we had 1 case of sympathetic ophthalmia also. All these patients showed significant improvement in vision with the mean injections of at least 2. We have these patients have we have a follow-up of 10 months. Now, till date, we have around 18 months of experience with this technique. One patient unfortunately presented with raised IOP, and we found that the drug was in the vitreous cavity. So the patient is still on AGMs and maintaining vision. So the take home to conclude is that SCTA, or suprachoroidal triamcinolone acetonide, is a potential alternative to intravenous methylprednisolone, and we can very well embrace it. Thank you. I thank Dr. Arun Bhargav because I've learned this wonderful technique from him, and I just want to give an acknowledgement to him. Thank you, Dr. JB, for giving me this opportunity to talk.
Wonderful, wonderful.
The presentation is open to discussion.
You can stop sharing your screen. Thank you.
Yeah.
Very nice. Manisha?
Yeah, Dr. Ale, your comments, please.
Yeah, it's actually suprachoroidal drug delivery is becoming very, very popular. Though there have been publications and approval of the delivery system, there are different kinds and different techniques. So, I mean, what is your technique of giving? Is it through a cannula or is it through a catheter? How do you define?
So I would call it. We devised this technique with an experience with Ozurdex. So we started giving Ozurdex for serpiginous like choroiditis, and then when we actually noticed that if we can use the same kind of needle to deliver the drug right at the pathology, so we devised a way where we use a 30 gauge needle and we railroad or make a sleeve of 23 gauge needle over it, so that just 1.5 or around 1.3 millimeters of the needle is exposed, which actually goes directly into the suprachoroidal space. So the technique is very simple. There's a give way when you give the injection, and can be given like an anti-VEGF injection 4 millimeters from the limbus. And once when you give the drug, so the potential space is around 250 microliters. So we can actually titrate the dose, but we don't have any consensus on that. So we 0.05 ml is probably 2 milligrams. So once we give the drug, an indirect confirmation is that the patient has a pain. So it is an indirect confirmation that the drug is in the suprachoroidal space. Unfortunate for the patient, but we definitely know that the drug is there. And then we
essentially it's a blind procedure. I mean, that is the main concern of most people. And that's why it's not everybody is jumping into a suprachoroidal drug delivery system. I think the catheter method, which also has a lighted bulb. So I think that is more defined because you can actually see the light going on if you do the simultaneous indirect ophthalmoscopy, and you can judge at what plane you are. So probably we need some kind of visualization. The other issue is we are not sure of the depth or the thickness of the sclera and choroid, which is not uniform in all these patients. So probably the patient in which you had the perforation might be having a thinner sclera or a thinner choroid. So it's not uniform. So that's again an issue that it's not a definite depth which is equal in all patients.
Dr. Amit, my only apprehension in this case is that it was a one-eyed patient that you were dealing with, and it was a frank infective pathology. And we know that the abscess is very much at that site or the local area where you are injecting a deposteroid. If by chance that the infection is not responding to the ATT being given, something like a multi-drug resistant TB, or the infective element is more, then don't you find this to be far more risky? Because if I have a patient who's on oral steroids and ATT not responding, at least I have something in hand where I can stop. But here you are actually injecting a deposteroid right at that site where the infection is. So don't you think that's a little too risky in this patient?
Absolutely, ma'am. This is one of the concerns. But we attempted this because we have a good amount of experience with such patients, and we've been treating tuberculosis uveitis now, with this technique. And I thought we actually thought that probably we should go ahead and do this. Yes, a one-eyed patient was a concern, but since we required an inflammation control, intravenous methylprednisolone was a concern for the patient as well at this point in these times. So I think because it was our confidence levels, we probably went ahead and did. But yes, the concern is appreciable, ma'am.
What is the incidence of secondary glaucoma, Amit?
Yeah, so in our in the cases which I have discussed, we had 7 patients. There was just one patient who had a raised IOP. The patient is still on AGMs, but that we found that the drug, a few of the crystals were in the vitreous cavity. So when the drug comes in contact with the lens epithelium, probably traverses through the zonules into the anterior chamber. Probably this is one of the reasons why the patient might have a raised IOP. But if the drug is in the suprachoroidal space, which we actually also confirm by a fundus examination after the injection, half an hour after the injection, we are pretty much sure that the drug is into the suprachoroidal space. So the chances of raised IOP are probably is a concern, but right now we are still analyzing the data and seeing. But as of now, we don't have any patients who have pretty much amount of raised IOP. No patient developed cataract progression till now in our follow-up, ma'am. No, sir.
Fantastic.
I just have a point actually, like what Manisha mentioned. So, especially when you're dealing with infection and you have a deposteroid to be injected, which is not even intraocular in terms of in the vitreous, we have to have a little bit of caution because there are 2 dictums we have to follow. You know exactly what you're dealing with. And second, you have to see the response of the medication, what is being administered to the patient. And third of all, if at all the deposteroid is being administered, once you see a response and then you know that the drug is sensitive to the organism which you're trying to do, is the antimicrobial agent should be covered as long as the deposteroid is going to be there. So unless and until all these 3 factors are being considered, there is a possibility that in rarest of the circumstances, sometimes this patient can land up in panophthalmitis and lose the eye as well.
I echo what Avinash is saying. My only apprehension for SCS would be suprachoroidal injection would be I cannot take out that deposteroid anyway. Ozurdex can be removed with vitrectomy. A subtenon tricot can be removed in if it does not work, but a suprachoroidal cannot be reversed, I think. That's why I would give it as a second injection after I have tried out tricot, peribulbar or intravitreal. But first time in an infective, I would definitely be very, very apprehensive of giving suprachoroidal, not because it is not effective, but because I cannot reverse it.
Dr. Salil, any comment from you?
Salil, are you online?
No, he is missing.
Oh, what happened to him? I just wanted to ask Amit, Ajay Arora has developed a small instrument, a small beam, which you know exactly what plane you're going, and what distance you're going into the choroid, suprachoroidal space. Have you used that?
No, sir. We haven't. We don't have any experience with that. But probably it works well in Sir's hands, so probably it's good for him. But we practice a simple technique, which is kind of an Indian jugaad for that. So it works well for us, sir.
Mohan, that is also, it's got a pre-designed length. So when you go into Ajay Arora's device, you just keep it at the desired place. And when you put your needle through it, it just comes out only as much as is required. So it's a very easiest way of giving a suprachoroidal injection, and it has been well accepted by people who are using it.
It is quite impressive because we did a live demonstration in our surgical strikes.
Yeah, we can have that.
And it was very good, very impressive, very impressive. The only problem is the blind technique. That is where you know exactly which plane you're going. That's the problem in this suprachoroidal. But Salil is not there, Manisha?
No, sir, I don't think so. Probably, sir, you can conclude the session then.
Yeah, you can conclude the session. You can conclude the session, Manisha. You can.
I think thank you, Dr. Manoj, and all the interesting cases that have been presented by the various speakers. And I would also like to thank all the panelists. Apparently, I think Dr. Biswas handed over this responsibility to me because we have to attend another meeting. So I took over midway. So it was really interesting and a great learning from all the cases which were presented today. So thank you once again for participating in this session on uveitis.
Thank you.
Thank you. Thank you.
Thank you very much for all the panelists and the speakers. And we'll
Thank
go
you.
on to the second session, that is the retina session. And I will share my screen first, and then Rajiv will share his screen. Okay, Rajiv?
Yes, yes, sir.
Okay, right. We finished with Amit Palkar, and now we have the retina session, and we have none other than the greatest of all, I would say, Rajiv Raman. And as I told you, he is the father of artificial intelligence in this part of the world, and he has done tremendous work, and a very, very close friend. Is one of the, what you call, pillars of the Shankar Netra Alumni Association. I'm very happy that Rajiv Raman is taking a lot of interest in our association as well. Many awards and accolades, which is beyond. I think it will take another 2-3 days for me to read about it. But Rajiv Raman will be moderating this session. Then we have a fantastic, what a galaxy of panelists to take care of the retina session. Muna Bende, Senior Consultant and Deputy Director of the Vitreoretinal Service in Shankar Netralia, prolific vitreoretinal surgeon, and along with Pramod Bende, they're doing a wonderful job. Kerobi Lakiri, my very, very close friend, my close friend, along with me in, when we did VR fellowship together in Shankar Netralia, and she's a consultant in Bombay Hospital. She's specialized in pediatric retina, especially in ROP work. She's actually the gold standard in ROP. Giridhar doesn't require any introduction at all. He's a medical director, chief mentor, Giridhar Eye Institute, which is a tertiary eye care institute, is also a postgraduate institute of ophthalmology. And Giridhar is the I would say, is the guru of everybody, for everybody. And, very humble person, but very, very competent, very, very knowledgeable. Vatsal Parekh, again, he was also doing fellowship along with me in Shankar Netralia. He runs a very, very busy eye institute in Bombay, top vitreoretinal surgeon, Drishti Eye Institute in Bombay. Parveen Sen, senior consultant, vitreoretinal department, Shankar Netralia, several peer-reviewed publications. She is a specialist in ROP, retinal imaging, pediatric retinal surgery, electrodiagnostics, and so many other things. And we have a fantastic, really fantastic panel. And I stop sharing the screen and request Dr. Rajiv Raman to take over.
You can share, sir, your slides. I'll continue with that.
Okay.
I'll continue from there.
I'm sorry.
No problem. No problem. So it's my pleasure to introduce the chief speaker, one of our guests, Professor Shobha Shivprasad. And I'm sure our alumni and all the members here don't need her introduction, but just to tell a brief, she's the medical retina consultant ophthalmologist at Moorfields Eye Hospital, NHS Foundation. She has more than 250 publications, and including some of them in the very prestigious journals like Lancet. She is editor-in-chief of the journal Eye since 2018. She has several accolades, and some of them, just to mention, is the NIHR RCOF Researcher of the Year, the Macular Society Rising Star Award, the RCOF Nettleship Medal in 2019. And that was actually, in last 10 years, it was the first time this award was given. And her association with Shankar Netralia, I would say it dates back in 2010 when I had contacted her when we did the DR meeting. And that time, Dr. Shobha presented overall epidemiology of diabetic retinopathy in Asia and in UK, a beautiful talk. And currently, she's associated as a principal investigator in one of a very important study, a grant which we got, the Global Challenge Research Collaboration Grant between India and UK. And last 2 years, I've been really more in touch with Dr. Shobha. And Dr. Parveen was mentioning very recently that No, and it is very much true that after Dr. Tarun Sharma, I would say Dr. Shobha is one of my mentor. She's mentoring me now in my journey in diabetic retinopathy. Welcome, Dr. Shobha. And she would be talking to us on a very important topic. Let me just finish all the other introductions. So we have Dr. T.P. Vignesh. He's an ophthalmologist, retina specialist at Arvind Eye Hospital, Madurai. And I would say he's the pillar of medical retina at Arvind Eye Care. He has a lot of international, national publications, a lot of papers he has presented, and he has attended numerous eye screening camps. And as I told you, he's a pillar of medical retina. Majority of the things of medical retina at Arvind, he's the part of it. We have our alumni, dear Rupak Vishwas, a senior consultant, executive director at Netrinilium and BBI Foundation with us. Sir, can you put the next slide? Dr. Pradeep, my colleague, a senior consultant at Shankanetralaya Vitreoretina department, a very humble person. And the 4 talks which we have, they are all specialists in one or the other thing which I'll be sharing when I tell about the talk. We have Dr. Raja Narayanan. Welcome, Dr. Raja, for this meet. He's a director, network, head clinical research at LV Prasad Eye Institute, head operation and system, Kalamaji Reddy campus, and I'll not pronounce everything, but he is basically my good friend and a senior retina consultant at LV Prasad Eye Institute. Next.
That's all.
That's it. So I think all introductions are over, and I welcome Dr. Shobha to start her keynote address on central retinal vein occlusion. What is the evidence now? So she'll be telling us some evidences on CRVO management. Dr. Shobha, please.
Over to Shobha. Madam, you can share your screen.
Yeah, I'm trying to.
Yeah.
Yeah.
Are you seeing my screen?
Yes, we can see your screen.
You can see your Zoom. What is that?
Yeah.
That's right.
Can you see that now?
No, we are just seeing
Not
your
able to see the screen, ma'am.
Your screen is Zoom is seen, but you just open your presentation and make it full screen.
I did.
Minimize this and open your presentation.
Yeah.
Oh, sorry about this. I don't know what is happening. It's not coming up.
No, madam, you need to share your screen.
I did, but it's not coming up.
Click on the PowerPoint presentation.
Yeah, that's exactly what I did.
Okay, ma'am.
You keep your presentation open, Dr.
It is
Shobha.
open. It is open.
And now share.
Let me just get back.
Yeah, that's good, ma'am.
Oh, it's come, is it? Okay.
It comes.
Okay, that's good.
You can put slideshow.
Yeah. So I think it's good evening there, isn't it?
Yes.
Yeah. So thank you for the invitation. I'm not an SN alumni, but I'm very glad to be with all of you today. So my presentation today is on an evidence management of central retinal vein occlusion in related macular edema. As you all know, I work in London, so my pathway that I'm going to present is very much an NHS pathway, may not always be applicable to India, especially because NHS is free to our patients, so I don't have to worry about the cost, insurance, etc. So it may not always relate to it, although I'll try my very best to be as close as possible to what we do in India. So these are my financial disclosures. So if we see a retinal vein occlusion, we usually see them in casualty or in the emergency unit. They usually present acutely. And the first point we have taught all our trainees is that we need to know whether it's a central retinal vein occlusion. And that's defined by a retinal venous dilatation and tortuosity, and it should be in 4 quadrants, and the hemorrhages also should be in 4 quadrants. So there are some difficulties, especially in people with diabetes, where there may be an asymmetry of diabetic retinopathy, and often there may be mistakes made of thinking that the more severe eye has CRVO, but typically the central retinal venous pressure will be normal. So that's the teaching point. Another disease area that we always get confused about is ocular ischemic syndrome. Here you may get venous dilatation, but there's often no tortuosity. So that is how in the clinical examination you can differentiate the two. Then of course there are bilateral cases like congenital venous tortuosity, hyperviscosity syndromes and things like that, but they're usually bilateral. So once we have determined our diagnosis, we have to clearly state whether it's a CRVO or a hemiretinal vein occlusion or a branch retinal vein occlusion. In the acute investigation and emergency, we enforce that all patients with CRVO should have their blood pressure taken. It may sound easy, but it's often missed, and it's a very big litigation procedure here if you miss blood pressure estimation. And it's just because patients fall within the system. We expect the GP to look after their blood pressure and do not take it in the casualty, or the casualty doctor will think it's a central retinal vein occlusion. The medical retina team will look after it, and somehow every one of us get the blood pressure missed, and that is often a big problem. And that's a very big question mark for us. If a blood pressure is not done, everybody is in trouble. So although the teaching says central retinal vein occlusion can be broadly divided into ischemic and non-ischemic, we often know that there is a big group of indeterminate CRVOs where diagnosis is pretty difficult. About a third of patients who present with CRVOs, we find it very challenging to differentiate them between ischemic and non-ischemic due to the hemorrhages. So fluorescein is often delayed because of that. But I want to bring out that the ischemic versus non-ischemic, as defined to us by Sohan Singh Here, is easy if the clinical diagnosis is very clearly we are able to demarcate all the signs that he has suggested. Example, poor vision, RAPD, or if we can do a fluorescein and it is more than 10 disc area of non-perfusion in a 7 field. Saying that that's often not the case in the clinic. We will have to differentiate between ischemic and non-ischemic, just looking at clinical picture, RAPD and vision. Often at times we do not do the fluorescein at baseline just because of masking of the hemorrhages. With ultra wide field angiogram, most of us have now got this facility, and the 10 disc area of 7 field is no longer correct. If you are using a ultra wide field, then it's usually about 30 disc area of non-perfusion is what we use to define ischemic central retinal vein occlusion. In addition to that, to mirror the 10 disc area, we also found that in patients with non-perfusion, only if the non-perfusion affects the posterior pole do these patients go into neovascular complications. So suggesting that may be the reason why the 10 field has worked all these decades of our practice, because even if you miss the periphery, it doesn't seem to do much harm to the patient. It is a central non-perfusion that matters. So once a patient comes into a medical retina clinic, then we have to look at what complications do they have. If there is neovascularization manifested as NV, angle, iris, or glaucoma, then it is immediate panretinal photocoagulation plus or minus intravitreal Avastin. If it is a confusion between ischemic and non-ischemic, we err on the side of it being ischemic. And of course, the most common complication and visual impairment due to CRVO is macular edema. In a patient with iris neovascularization, our management in the UK is immediate intravitreal Avastin plus PRP, whatever be the visual acuity. Of course, we do need to check the angle. There is a huge confusion about whether we should be using anti-VEGF therapy for iris neovascularization and ischemic CRVO. The RAV study done by David Brown in the US, although a very small data base of patients, it clearly shows that despite intensive ranibizumab therapy for 9 months and then monitoring with PRN ranibizumab and then followed up for 36 months, what we find is all what anti-VEGF does in CRVO is to delay the complications of the condition. So clearly we do need to do PRP if the patient has got ischemia with risk of neovascularization. There was a teaching in the UK, especially that if you have ischemic CRVO, you don't need to treat them with pan-retinal photocoagulation unless they develop NVI, NVA, or NVG. But I think over time we have learned our lessons because these patients do not come back in time and they turn up with these complications. So I would rather be aggressive and treat them, if they're ischemic, treat them with pan-retinal photocoagulation, and for their macular edema, treat them with anti-VEGF. That is probably the best way to go. Regarding treatment of neovascular glaucoma, I'm not an expert in that area, but if a patient presents with perception of light only, with high intraocular pressure, angle is closed, no potential for a gain in visual acuity with any form of treatment, and the patient has no pain, then we do nothing. If he has perception of light, pressure is high, angle is closed, and has got severe pain, then of course he proceeds with pan-retinal photocoagulation and cyclodiode. In all other cases, I would say, whether it's almost closed or only a bit of the angle is closed, we encourage tube plus anti-VEGF and pan-retinal photocoagulation so that the patient gains any amount of vision. Again, we need close monitoring of these patients in both the glaucoma service and the retinal service. Coming to macular edema. So I know this is an elegant symposium, but I should say my talk is all about anti-VEGF. I have very few slides on Ozurdex because our main treatment in the UK is anti-VEGF. So any patient with macular edema, we start them on anti-VEGF immediately. We do not look at the visual acuity criteria. As long as there is evidence of macular edema induced visual impairment, we start the patient on treatment. Without macular edema, of course, we observe. Most of the patients are young in those cases, and they need to be observed closely because the macular edema can develop later. So I'll go through the efficacy, the outcome, and how we treat our patients in the NHS. So based on the CRUISE data, we all know that ranibizumab works, and it works pretty well. And if you start the patient on anti-VEGF beyond 6 months, then the patients are unlikely to gain visual acuity. Now, this one, you can see that the patients were given monthly injections throughout. And when they reduced it to a PRN basis in the horizon part and the retain part of the study, taking the patient on to about 48 months, you can see the visual acuity dropped. So CRVO has got the highest VEGF levels in the aqueous and vitreous, and therefore requires far more anti-VEGF treatment than diabetes or AMD. Eylea, same thing. 6 monthly injections, did pretty well, continued the same regimen till 12 months, pretty good at maintaining about 3-line gain of vision, and then it drops as soon as the patient is seen every 12 weekly, suggesting that the CRVO patients require many years of treatment. So we have the LEVO study, which we conducted in the UK, where we compared 3 anti-VEGF agents that we have, like Lucentis versus Eylea versus Avastin for central retinal vein occlusion. We recruited a total of 463 patients and randomized them into 3 arms. This time we gave only 4 mandated injections and then PRN, but we managed to see the patients every 8 weeks in the trial, and we followed them up for 100 weeks. Here you can see that all 3 agents improved the visual acuity pretty well to about 2 lines at least of gain of vision. But we also noted that ranibizumab versus aflibercept, you can see that aflibercept was non-inferior to ranibizumab. But when we compare bevacizumab to either ranibizumab or aflibercept, it was not non-inferior. So the macula was thicker with bevacizumab, the visual acuity was poorer with bevacizumab, and it required a lot more injections. So we have to bear that in mind. And this is aflibercept versus bevacizumab, again showing that aflibercept bevacizumab is not non-inferior. I can't use the word it's inferior, apparently due to statistical reasons. Now, when you compare all the anti-VEGF trials that we have, you can see that the LEVO study had a very high baseline visual acuity, had a very few patients with a long duration of central retinal vein occlusion, and most of them were treatment naive. We took on every patient that came from the casualty, that is from 19 ETDRS letters to 78 ETDRS letters. So it's a very generalizable study to the public for new CRVO patients. And what you can find here clearly elicit that all the trials showed 6 mandated injections were required. We went for 4. The main reason was at the time when we were deciding with the trial, cruise was the only data that was available. And it did show that after 4 months of injections, it stabilized. So we thought at that point that the 4th and 5th month injections can be made PRN and not mandated for all patients, just to make it, just to prove the point that all patients do not need 6 injections. That was the plan. But you can see from the 100 weeks results that when we did the 4 mandated injections, definitely all 3 arms showed very good visual acuity improvement. But when we ended up with a PRN in the month 5 and 6, you can see that the visual acuity dropped by 3 letters. Again, it was correspondingly, you see an increase in central macular thickness at that time, proving that all patients with central retinal vein occlusion actually require 6 mandated injections. And there'll be a rare number of patients who do not need it, but we are unable to determine who they are. So it is safer for us in the NHS at least to give 6 mandated injections. May not be practical in a country where patients have to pay for the injection. What about the longer term effects of central retinal vein occlusion? So you can see when for our 3 anti-VEGF agents, aflibercept required the least number of injections at 52 weeks as well as at 100 weeks. What we found is when we go back and look at the Galileo and Copernicus studies of aflibercept in central retinal vein occlusion, you can see that if the patients are monitored every 12 weeks, that is only every 3 months, the visual acuity drops. Clearly shown here. While the Crystal study that looked at ranibizumab at bi-monthly monitoring, they were able to maintain that vision even if the injections were given on PRN basis. So patients need to be monitored very closely. And that's exactly what happened in the LEVO study as well. For the rest of the 100 up to 100 weeks, we managed the patients. We saw the patients every 4 to 8 weeks, depending on whether they needed met their retreatment criteria. And you can see a stabilization of visual acuity and no drop during that time. So the next question is, how long should we be treating these patients? Our earlier trials suggested that we could do it for about 100 weeks or 2 years, but now with more and more data coming out, it looks like CRVO is a long-term condition requiring up to 5 years of therapy and an average of about 3.5 injections from year 3 to year 5. We don't have data beyond that, but at present it suggests that we should not be discharging our patients early because most of the CRVO patients have some degree of ischemia and macular edema recurring all through to year 5 so far. So coming to the SCORE study, the SCORE 2 study then asked the question of whether we should be giving them monthly injections or PRN, or treat and extend regimen after the 6 loading doses. So this is what it that. So after 6 loading doses, the aflibercept and bevacizumab arms that responded well, all those patients were then randomized into treat and extend versus monthly aflibercept, or the same for bevacizumab. And you can see that there were very, very few non-responders if you give 6 monthly anti-VEGF injections. In aflibercept, you had about 31 patients, I think, and bevacizumab, very, very small numbers. So it clearly shows us that if we are very regimental in the way we apply anti-VEGF, then we do not need any other treatment. Now, aflibercept non-responders were switched to Ozurdex after month 12, and bevacizumab patients were given aflibercept after month 12. And you can see for SCORE2, if you give monthly injections, again, the visual acuity improved really well. And it also showed that treat and extend patients did just as well as monthly injections. So clearly you don't need monthly injections all the way after month 6. So in summary, all these anti-VEGF trials tell us that anti-VEGF causes substantial gains in vision, but we have to give 6 loading doses. And then after that, see them every 2 months at least. But aflibercept is associated with lesser number of injections compared to the other 2 anti-VEGF agents. Now, visual acuity loss while patient is on anti-VEGF treatment is most probably due to the conversion of patients from non-ischemic to ischemic, and due to increasing ischemia causing macular non-perfusion. Very rarely it can cause anterior ischemic optic neuropathy as well. So it's all ischemia that causes the loss of vision, and very unlikely due to a non-responding macular edema. Coming to Ozurdex, we have the Geneva study where Ozurdex was given every 6 months. But here you can see that the visual acuity gains were about 50% less than with anti-VEGF therapy, with less number of patients gaining 15 letters or more. And of course, cataract and intraocular pressures are a concern. I know this is very often used in India, and I'm not saying it shouldn't be used, but I'm just comparing it with anti-VEGF injections. And if we had no issues with insurance or money or patient time or patient coming in, etc., then probably anti-VEGF is definitely the way forward. So in summary, I would say that any RVO patients, the first point we have to remember is to take their blood pressure and make sure that blood pressure is managed. We have to diagnose macular edema early and treat them early with anti-VEGF as our first choice. Pan-retinal photocoagulation should be done in all patients with ischemic CRVO, irrespective of their neovascular complications. And aflibercept is our preferred choice because it has less number of injections and a better drying effect. Of course, then it also depends on the health system as to which agent you use. Thank you.
Wonderful. Really wonderful.
Yeah. Can you just
share?
Yeah.
Rajiv?
Thank you, Dr. Shobha. It was really a great talk and we learned a lot. It's I thought that I should ask Dr. Raja a comment because he has done some very good work, the Marvel study. This is one of the clinical trial which was done in India and he's the principal investigator. So I think, Raja, can you share some of your views as far as the Indian scenario on vein occlusion is concerned?
Rajanarayan is there?
Yeah. Raja, are you there? Yeah.
Not there.
No, I can see him.
You probably unmute yourself, Raja.
Raja, can you unmute? Okay, Raja is not there. Dr. Munabinde, can you share your views? Indian thing, do you feel anything is different or we follow the same things?
Thank you, Raja, and sure, Rajiv. Shobha, that was a wonderful talk. I think what we need to take home is there is still a role for PRP in these patients, and I think that's what we follow. And your paper on posterior non-perfusion, I was just reading it today. I think that gives a lot of information because we feel that unless you have wide field, you cannot evaluate. Now we know that posterior non-perfusion is equally important. And I think we all need to understand that we are only postponing neovascularization by giving anti-VEGFs, and that's something we need to keep in mind. Ozurdex has a role probably in our patients because of financial issues related to aflibercept, but hopefully things will get better now.
Yeah.
But I think we've had fairly good results with Ozurdex as well. I've done a study where we gave more than 6 Ozurdex injections for patients with RVO, and they did stabilize eventually, though a few of them finally we switched to aflibercept.
Can I say something? Can I just?
Yeah.
I mean, as far as vein occlusion is concerned, Dr. Shobha, I was wondering why are they looking at visual acuity improvement as a very important factor? Because in many patients with vein occlusion, there will be maybe macular ischemia. And once you have macular ischemia, visual acuity, whatever you do, vision is not going to improve. So basically, I mean, unlike diabetic macular edema or other conditions, vascular occlusion is entirely a different ballgame. And a substantial number of patients have poor vision due to ischemic factor, which cannot be corrected by anti-VEGF.
That's true. I mean, the only two reasons, or the main two reasons of loss of central vision in CRVO are macular edema and macular ischemia. And at present, all macular edema, all anti-VEGF will do is to reverse the macular edema to a certain extent. There's nothing we can do for the macular ischemia. So yes, we can control it, but
Therefore,
not prevent it.
What I meant to say is, when you compare the efficacy of drugs in any trial, the initial patient profile becomes very important.
Yeah.
So if you have a reasonably large number of patients with macular ischemia along with macular edema, obviously these patients are not going to show any much improvement in visual acuity.
That's correct. When we look at all the trials, less than 5% of the patients actually lose vision. So a large component of the visual impairment in non-ischemic CRVO, as we call it, I mean, with ischemic patients, of course, it's a completely lost game before we even start. In that group, if you look at all the trials, it's less than 5% of patients actually lose vision or have a drop of more than 5 to 15 letters. So macular ischemia is definitely there for sure, and it progresses over time. We ourselves have shown that. But I think we can at least treat the macular edema for them. That's what it can do. I mean, even with steroids, I think all we are doing is to dry it up quickly for them so that it doesn't leave any chronic edema damages like epiretinal membrane, etc. But yeah, there's nothing for ischemia. That is the big research that we have to do. What can we do to improve ischemia? It's $1 million question at present.
So Raja is back. I think he had some audio issues. Raja, we would like you to give your comments about your MARVEL study, one of the clinical trial on retinal vein occlusions in India.
Yeah, thanks, Rajiv, and thanks, Dr. Shobha. I think MARVEL was for BRVO, and we all know that it's a much better disease to have if at all we are given a choice. So overall, I think in the MARVEL study, what we found was an optimization of the anti-VEGF treatments. In the first 6 months, we had a different treatment criteria, and in the next 6 months, we had a different retreatment criteria. And what we found was that the initial 6 months, the number of injections are much higher. But after that, if you look at the visual stabilization criteria, whenever the edema comes back, even if it comes back a little bit in BRVO, the vision in many cases doesn't go down. It stays stable. We use that opportunity that once you give the loading or initial 6 months, you look at the maximum vision potential they have achieved. They are in their what you call as cruising altitude. Initial lift off is there, then there's a cruising altitude phase. At that time, if you just, I mean, we added laser at that time. I mean, many people don't do laser now, but we did macular laser at that time. Whether that was the reason or even without macular laser, these patients may just suffice. If the vision drops along with edema, you give the injection. So if the vision doesn't drop and you don't, even if there is edema, you don't give injection, most of them did very well. In fact, they all maintained their vision at 12 months. So overall, it's a good disease actually.
I totally agree, Dr. Raja, with the BRVO concept. And actually, after 6 injections for BRVO, if there is parafoveal edema, we don't inject. I mean, I mean, not everybody follow what I'm saying here even, where people are very aggressive with just treating if there is any fluid. But parafoveal edema lying there, it will be there for 2-3 years in some patients without causing any trouble.
No,
So we
I
don't
like that comment, Dr. Shobha, that I know some people in the US have given 40 injections over 3 years. I mean, I couldn't say anything, but overall, I would say that it's a good, I mean, in the sense, good prognosis disease, you know, and even the neovascularization rates. I mean, unfortunately, at 1 year we completed the study protocol, but we also had patients coming at 2 years. Some of the patients develop late neovascularization, but definitely the neovascularization rates are much lower if you are giving anti-VEGF treatment compared to if you don't give anti-VEGF.
Yeah, I totally agree. I mean, BRVO is a very, very benign condition comparatively. Of course, there are ischemic types there as well. Even for ischemic BRVO here, we do not do PRP before we discharge them. We just tell them to come back if their optician noted any neovascularization or if they bleed, etc. Because we say exactly like what you said, we believe it's a much more benign condition. CRVO is a totally different ball game. I mean, it is very chronic, and if not treated, we are in trouble with that. Most cases.
I have a question for you, Shobha. If left to you, I mean, what would be your personal choice in terms of anti-VEGF? Would you prefer ranibizumab or this aflibercept in any patient of CRVO, if it's left to you?
Thank God I attend advisory boards for both of them, so I don't have any conflict of interest. And I can say I definitely will go for aflibercept. I want to give patients less number of injections for sure. If they have a better drying effect, and I know their visual acuity was about the same in both the LEVO study and what bevacizumab, aflibercept in SCORE 2. But if you give less number of injections, I think patients will be much happier. They are happy to come often, but if you say no injection to them, they're very happy as well. So that's the reason. They dry quickly, they maintain the dryness longer, and they less number of injections. That's why I prefer aflibercept.
Thank you.
Aflibercept you give once in 6 weeks or 8 weeks?
So it's monthly in the beginning until the patient dries up completely, then see them every 8 weeks and inject.
Okay.
I think any other questions or any other comments? Otherwise, we'll go to the 4 talks.
I'm afraid I have to leave now. I have another.
Thank you, Dr. Shobha.
Thank you, Shobha, for the wonderful.
Thank you, everyone.
Wonderful.
Thank you, everyone. Have a good evening. Yeah.
And educating all of us on CRVO is a very, very important topic for all of us. You know, it's very, very. We are always in a clinical dilemma whether to go for the Lucentis or Eylea or Ozurdex or whatever it is. You have cleared everything. Thank you very much.
I don't know whether I cleared it, but definitely it's a very difficult disease, I should say. When I first started with anti-VEGF, I just thought, oh, we got indication for AMD, now we got it for diabetes, then it came for CRVO. I thought it was pretty simple. But it's only then previously we never had treatment for CRVO, so we never learned about the condition well enough. But once we started, I realized this is the worst condition to have and the most difficult to treat. So.
Yes.
In a few months, you may have another option of brolucizumab, or a few years, we may start discussing that.
I don't know. I don't know whether in a public forum I should be saying that, but in the RAVEN study, we are part of it. So it's going to be brolucizumab versus aflibercept and the same treatment regimen. I mean, it's only recruiting yet, but the initial observations that came out from the AMD trial did frighten all of us. So hopefully things will change over time. I mean, we don't really know whether it will change or whatever.
Thanks for your frank opinion. Yes.
Very nice.
So let's start with the next 4 talks. And I think the 4 people which we have with us who will be giving the next talks are experts. So they are expert. The reason why we thought of these 4 talks, because all of them do one thing a bit different from others. And we thought that let's learn from these masters that how they manage. So we have Vignesh. So Vignesh is a master in doing micropulse lasers and a lot of other type of managing CSR. So he will be telling us about my way of managing central serous retinopathy. Vignesh.
Yes, sir. Good evening, everybody. I thank Dr. Mohan Rajan sir and Dr. Rajiv sir for this opportunity to speak on central serous choroiditinopathy. I'll just share my slides. So here I'll be telling on my approach to in the management of central serous choroiditinopathy. So before that, a few basics on the CSCR. It is one of the commonest disease like producing visual impairment in the working age group. The fourth commonest maculopathy, characterized by serious macular detachment with or without PEDs, predominantly affects males. Male is to female ratio of 6:1. Average age ranges from affects in the range of 30 to 55 years. And the BCVA can range from 66 to 660. And usually they complain of central scotoma, metamorphopsia, and stomatoxia. So there are various risk factors like type A personality, stress, especially this post-COVID, we are seeing a lot of CSCRs, acute CSCRs, because of the stress like of post-COVID, like economical reasons, as well as like staying at home without work, like a lot of people lost their work also. And also the steroid use in any form, psychiatric disorders, endogenous hypercortisolism, pregnancy, uncontrolled systemic hypertension, sleep disorders, especially obstructive sleep apnea, peptic ulcer, H. pylori infection, as well as GERD in patients with renal and bone marrow transplant who are on long-term steroids and certain drugs like oxymetazoline, which is used for the nasal condition, pseudoephedrine, phosphodiesterase inhibitors, and MEK inhibitors, as well as smoking and alcohol. So all these risk factors like have to be eliminated before we start treating the disease. So I just wanted to discuss on these risk factors also. The pathogenesis, the primary pathology is thought to be in the choroid. There is choroidal venous stasis, choroidal ischemia, choroidal inflammation, and we can see this choroidal hyperpermeability in the ICGA. And also, like recently, like we have this involvement of the aldosterone and mineralocorticoid receptor pathway. So this eplerenone is being used in this for this mechanism. And coming to the clinical subtypes, we have acute CSCR, like especially like the less than 3 months duration, minimal RP involvement, and usually resolves spontaneously in 2 to 3 months if we remove the risk factors, as well as like focal leaks are seen in FFA. Chronic CSCR, like more than 3 to 6 months duration, extensive RP involvement is seen, usually does not resolve on its own and leads to progressive visual loss if not treated. Focal or diffuse leaks on FFA, and especially like flat irregular PEDs are seen in chronic cases in OCT. Recurrent CSCR, acute as well as chronic can recur, but chronic has higher chance of recurrence, and up to 50% of cases can recur. Bullous variant is a rare manifestation of CSCR, like where there is serious macular detachment with severe fibrin exudation and inferior bullous exudative RD, especially seen in patients on long-term oral steroids and post-transplant states, as well as some cases like presented to me like without even any history of steroid intake. So coming to the management of CSCR, so the acute CSCRs usually are observed because they are self-limiting with removal of risk factors. The other option, the other modalities are laser photocoagulation, the green laser, the conventional green laser, 532 nanometers, transpapillary thermotherapy, photodynamic therapy, it is considered the gold standard, half lens or half dose. And the other two are the micropulse yellow laser and eplerenone, like which I am doing in my patients. There are several agents which have been used, but still they don't have enough scientific evidence to use as a therapy in CSCR, like mifepristone and others. So I'll be basically concentrating more on micropulse and eplerenone. But initially we were doing transpapillary thermotherapy, and one of the like we published a study long time back where TTT was done in long-standing CSCR with subfoveal leaks and with a very good resolution and nearly up to 96%, and as well as very good improvement in visual acuity, significant improvement. So this we were doing before, but right now, like once the micropulse laser came, like it was much easier to do than TTT. So I switched over to micropulse laser. The subthreshold micropulse laser protocol is we use the IRIDEX IQ 577 nanometer, the yellow laser, a spot size of 100 microns, duration of 200 milliseconds, and duty cycle of 5% is used. First test burns are in the micropulse setting are given in the infranasal quadrant to produce a visible burn, and then we use the 50% of that power to produce a subthreshold burn, which are invisible. The area of leak or the wounds are then treated with contiguous subthreshold invisible burns. The other modality which I am using is eplerenone, the oral eplerenone, which is an aldosterone antagonist and a potassium-sparing diuretic used in the management of hypertension as well as heart failure. Before starting this, we have to make sure that the patient is fit enough to tolerate this drug. So we do a baseline serum potassium, blood urea, and serum creatinine, and we also take a friction fitness before starting the drug. And we start usually with 25 milligrams once daily orally for a month, and then increase it to 50 milligram. Hyperkalemia is a side effect, so serum potassium is monitored monthly, usually well tolerated in 25 to 50 milligram dose. So coming to the management of acute CSCR, so we usually observe for 2 to 3 months. Intervention and immediately if patient wants early visual recovery or the other eye has poor vision. Micropulse laser can be used as an option to the focal leaks and can be safely done in subfoveal and juxtafoveal leaks. Eplerenone can be used in acute CSCR if there are no leaks seen on FFA or patient does not want laser treatment. Right now, I'm doing a trial comparing eplerenone micropulse laser as well as observation in acute CSCR. Very soon I will be publishing it. So just to show this case, like a leak within the FAZ, I did subthreshold micropulse laser. Within 1 month, there was a very good improvement. I mean, complete resolution and the good improvement in the visual acuity. So which maintained for at least 6 months. In recurrent CSCR, usually treated immediately either with micropulse or eplerenone, but can be observed in like 1 to 2 months if visual acuity is good and patient is not symptomatic. Bilateral cases, I treat immediately. Chronic CSCR for focal leaks, unilateral involvement, micropulse laser is used. For diffuse leaks, bilateral involvement, eplerenone is preferred. And if there is no complete resolution with micropulse laser at the end of 2 to 3 months, laser can be repeated. Even after second laser treatment, if fluid persists, eplerenone can be added. When we are starting with eplerenone, if there is no complete resolution with eplerenone, FFA is repeated and micropulse laser is combined with eplerenone. So we did a study which was recently published where we compared micropulse laser with eplerenone. So both treatment modalities were effective, comparable favorable anatomical outcomes, but visual outcomes are not significant because of the chronicity of the pathology. So a lot of cases had diffuse RP changes as well as degeneration. Complete SRF resolution was seen in around 43% in micropulse laser and 20% in the eplerenone group. Baseline visual acuity was correlated positively with the final visual acuity in both groups. So none of our patients did not develop any side effects due to eplerenone. So another case of chronic CSCR, subfoveal smokestack leak, where I treated with the micropulse laser, and within my first month there was a very good improvement, and then vision improved to 6.6 by 3rd month, and it was maintained. This with micropulse laser. So eplerenone I'm like using in chronic CSCR with the cystoid macular changes, like with very good improvement in this situation, like where there is resolution of fluid as well as the cystoid spaces, and by 4th month vision improved to 6.6. Another case again, there was like good resolution as both the fluid as well as the cystoid spaces. With but however, vision did not improve in this case, but there was a good resolution in the fluid, both subretinal and intraretinal. However, not all cases respond so dramatically, but this case gave history of 14 years of CSCR. He came to me like this, the other eye being like 1/60 with the massive edema, and this eye had like right eye had edema like this as well as subretinal fluid. However, there was some reduction at the 2nd month, we can see here, but I told to continue the medication, but the patient had stopped by 3rd month. When he came to the 4th month, there was again recurrence. But I have advised to continue eplerenone. There was leakage throughout the posterior pole in this case. Maybe I have to plan to combine it with micropulse laser to the entire posterior pole. Another interesting case, the bullous CSCR, like where we see massive subretinal fibrin with detachment. Also, we are seeing here the inferior bullous detachment and diffuse multiple leaks. We can see here. So what I did was I gave first eplerenol. Within 2 months, there was a very good reduction in subretinal fibrin, as well as the leakage also came down. Then I did the laser to the remaining leakages. So here we can see like from baseline, the fibrin started like melting, like disappearing within 2 weeks of eplerenol, and then first month and the second month when the fibrin like was significantly reduced, then I gave laser. Third month like very good resolution. Again, the fourth month complete resolution. The vision improved from 660 to 6.9 in this case. We can also see here the bullous, the inferior exudate detachment like completely disappeared at the end of 3 months with this combination therapy of both eplerenol first to reduce the fibrin and also the leakages, and then to give safely the micropulse laser, because we may not be able to give the laser if there is a lot of fibrin and then leakage is over the fibrin. I mean, in that area of fibrin, we may not be able to give the laser adequately. So I followed this strategy to, in this particular case, to improve the vision from 660 to 6.9. So in summary, like CSCR, like acute, recurrent, and chronic, the way I manage is in acute, I first observe. Maybe it requires a holistic approach because like a lot of counseling needs to be done on stress management and as well as lifestyle modification and education on sleep hygiene. And we have to take a thorough history of steroid intake, like which patient maybe cannot be able to reveal because I mean he may not know like what kind of medication he's taking. So observation with removal of all the risk factors is the first line. But however, if patient wants like immediate visual recovery, I either do micropulse laser or eplerenol. And in recurrent cases, like mostly they are treated, and I either give one of these. And chronic cases, I always treat because we cannot leave chronic cases as such because there is going to be progressive decrease in vision as well as very rarely only like spontaneous resolution happen in chronic cases. I always treat either with micropulse laser or eplerenol. If there is no response in any one of these, then I combine. PDT is out of question in most of my cases because most of them are from the lower economic class and they are not able to afford PDT. Right now, PDT is also not available for the past 1 year. And many of my cases, after hearing the cost of PDT, the CSCR also got aggravated. And then I had to do micropulse laser in those cases. So PDT, I mean, I have kept out of my approach in the management of CSCR. Thank you.
Thanks, Vignesh.
Brilliant.
Thank you, sir.
Just unshare your slides.
Thank you.
So I think Dr. Vignesh gave a good approach, and I would ask Dr. Parveen because her experience on PDT, because we could not cover the PDT part. So what do you feel would be the approach for your cases where you'll try to use PDT for central serous retinopathy?
Yeah, a very good talk, Dr. Vignesh. And as you rightly mentioned, Rajiv, I am particularly fond of doing PDT.
Yes, that's the reason I've asked you. Yeah.
So we always do, but now that PDT is not available, I think I have to learn from Vignesh. So there's no choice now. So the first question I would like to ask you is, PDT, we have always done a ICG guided PDT. So how do you do the micropulse when you have ICG hyperpermeability, which are the areas we have traditionally been treating with PDT? So how do you use ICG to guide your micropulse laser?
In most of my patients, I use FFA guided. Only in very chronic cases, I do combine both ICG as well as FFA. But most of the cases I'm doing in FFA based to the leaks as well as the area of booths or the diffuse leaks which are seen in the FFA. I don't do routinely ICG for all my cases. Only in chronic cases or recurrent cases where the laser are straight, I combine ICG. Or if chronic cases from presentation, they're chronic, I do it. But I do only on the leaks per se, not on the any areas of hyperpermeability on ICG.
I think this is going to be the future thought for us, that we have traditionally been doing PDT, and PDT has been established to work better for chronic CSC as vis-a-vis micropulse laser. But now that PDT is not available, whether we can use micropulse in the same way that we have been using PDT is something which we will all have to think about.
Or
And
even go back to TPP.
one more thing that I would like to add is anti-VEGF in CSCR.
What I wanted to ask.
I always, in chronic CSCRs, recently we have noticed that there is a neovascular component which sometimes does develop, and these patients come with the, FIPED, or a flat pigment epithelial detachment, which could be, which could signify an underlying type 1 CNV. So whenever I see that sign on OCT, I prefer to do OCT-A to rule out presence of a type 1 CNV. And if there is a type 1 CNV, there is a definite role of anti-VEGF here. If there isn't, then of course you can go towards epileron, or you can do PDT, or you can do a micropulse laser. So this is how my treatment plan differs when I find a FIPED on OCT. And you spoke correctly of the cystoid changes in CNV, so in CSCR. So those cases also, almost 50% of these cases of PCDR will probably have an underlying type 1 CNV. So this is the role of, before the OCTA, we never believed that anti-VEGF worked in CSCR. But I think with the OCTA, we have this small niche group of patients who develop a type 1 CNV in CSCR can benefit by an anti-VEGF treatment also.
Sure.
No, thank you. I completely agree with you, madam. Like, and I am doing like OCTA in most of the cases with cystoid spaces as well as in FIPED. Like, not in maybe lesser percentage of cases, I'm able to pick up the type 1 CNVM where I use anti-VEGFs. But as anti-VEGFs without the CNVM component, like anti-VEGFs have never worked in those cases like of chronic CSCR where I have treated without any neovascular component. But I have started using OCTA recently for a few months, like past few months in case of FIPED, like other flat irregular PDs. And I rule out in type 1 CNVM like before treating epileron or micropulse. I forgot to mention that. Thanks for the.
I think, Parveen will agree that one of the advantages of PDT also is the very low rate of recurrence, especially in chronic CSCR, even up to 2 to 3 years. The number of patients who come back with recurrence is very low. So that's probably one of the biggest advantages PDT when compared to micropulse. I mean, yellow micropulse 577. The only problem is probably you need experience. I think you learn by doing more and more cases, because the main issue is inefficacy, unpredictability. Because even in your published article, you have said 12 out of 28 patients had no fluid. I mean, in your article where you compared epileron with micropulse, 12 out of 28. So that's not a big number actually, if you see, because when you give focal laser in patients with CSCR, it's very effective. At least, it works in more or less 100% of the cases initially. Patients may come back with recurrence later. That's a different issue. Therefore, micropulse is good. Subfoveal lesions, I think it's good. But then the main problem is this unpredictability as far as the outcome is concerned. Of course, it's very cheap. It's affordable.
Yeah. Any other comments from the panel?
I wanted to ask Dr. Vignesh. Dr. Vignesh, wonderful presentation. I had 1 or 2 questions for you. How often do you repeat your potassium and other parameters when you put a patient on epileron?
So first I check at the baseline. So I make sure that it is lesser than 5. And then like 15 days to 1 month is the requirement, like initially. then every month. So I explained all the side effects of eplerenone, like dizziness, giddiness, means muscular pain, cramps that can develop because of hyperkalemia. And so any of these symptoms the patients develop, so I tell them to stop the medication and to come for a review. If they're developing this, they have to do an immediate serum potassium. Otherwise, every month or so, and then until I continue the treatment, I go on with monitoring serum potassium. At any point of time it crosses 5, I stop it. But actually 5.5 is the cutoff. But I want to be very safe with these patients. Yeah, so I don't want any of the patients to suffer because for this therapy. So I make sure that I clearly explain to them and then start the treatment. That's the only thing, counseling part I have to do. But laser. Yes.
Okay. Another question which I had for you was that, see, there are patients who are put on steroids and they develop the CSR. They may have been treated earlier, but yet they develop it again if they are put on steroids for any other cause. So you have patients of uveitis who come back because they have been put on steroids. And even now in this COVID era where people are being put on steroids, you feel quite a few of them do land up with a recurrence of a CSR. So what would be your take in these patients, and how would you sort of advocate or advise them, what is to be done about the role of steroids for any other condition that they're going to get treated?
Yes, sir. It's really quite challenging in such cases because even just a week back, I saw a patient of polycystic kidney with post-renal transplant having severe exudation and cystoid macular degeneration. But the thing is, steroids cannot be stopped in that patient because even the kidney which has been transplanted is failing, and he's on immunosuppressants also. So what I do is whenever steroid can be substituted by other immunosuppressive in transplant patients or other agents like in rheumatoid arthritis or SLE, I would discuss with the treating physician and try to substitute steroid or reduce the dose of steroid and then start my treatment. But many are unfit for starting eplerenone in such scenarios, especially post-renal transplant. So it's difficult. So what I can do is even FFA cannot be done because of increased renal parameters. So I can what I plan in such cases is ICG based micropulse laser treatment, in such scenario. Once I get the fitness from the physician. So, but always I try to reduce the dose of steroids or substitute the steroids with other immunosuppressants.
Dr. Vatsal, your views about this?
Rajiv, I have a question basically to all panelists.
Yeah.
I've used eplerenone for probably 10 patients and I was not greatly impressed.
Yeah.
Like what we hear in presentation. So just I wanted to know other panelists' view on this.
More importantly, Vatsal, the troublesome side effects the patients are not able to tolerate. In my experience, at least after a few weeks, they develop a lot of side effects and they discontinue. The compliance is very poor in my experience. I'm not sure about the other people. Vatsal, I agree with you.
Dr. Munna, your view, madam?
Yes, I have had a few patients with eplerenone, and maybe 3/4 of them got better. No one complained of any problem, but I found that I was stopping it because potassium went up. And probably, Dr. Vignesh, that was a nice talk. I just wanted to ask you, since you have option of micropulse, which you treat based on your fluorescein, and you have the option of eplerenone, if you were to do an EDI imaging and made a diagnosis of pachychoroid, would that shift your line of treatment either towards eplerenone or keep it still at micropulse?
Actually, eplerenone can be given in all patients, like both pachychoroid as well as non-pachychoroid. But only because of the concern of side effects, I limit the use of eplerenone. But I have treated more than 100 patients. I just got only 3 to 4 patients who had to stop eplerenone because of the side effects. And those 4 could not tolerate. 96 patients, whom I treated, were free of side effects, and they could easily tolerate 25 to 50 milligram. And only 1 or 2 patients had to stop because of hyperkalemia. But yeah, pachychoroid, we have evidence that eplerenone reduces the choroidal thickness as well. So my pachychoroid is confirmed. I would always go for eplerenone. Only when eplerenone cannot be given, I may go for micropulse.
Thank you.
Sure. So I think we will go to the next talk, and the next speaker is Dr. Pradeep. And Dr. Pradeep he's a master, or I would say he's a mentor to many of the people who do macular buckle today in myopic maculopathy. And he has expertise in myopic maculopathy overall. So Dr. Pradeep will talk to us on the role of whether to use you do vitrectomy or a macular buckle in myopic macular tractional maculopathy. Dr. Pradeep.
Thank you, one and all. Thanks, Rajiv, for giving an opportunity here. 5 minutes slot was short for, I think I'm audible, right?
Yeah, you're audible.
Okay, and it was little shorter for a myopic maculopathy of a broad entity. So I thought I'll confine myself in this next 5 minutes to how to choose between the vitrectomy and the macular buckle in myopic traction maculopathies. So the association of posterior staphylomas with a myopia is an essential component when we use the term myopic traction maculopathy, or MTM. And universally, maculoschisis is one of the findings which you see in all the spectrum of MTMs. Along with all these things, there's a very well described in the literature. So the options available for us in the management of MTMs are, most of the cases in the mild or moderate, we can just observe them over a period of time, a little less progressive. When we go towards the surgical option, then most cases can fall into the category of vitrectomy, with lot of modifications noted on the literature, whether with or without ILM maneuvers, peeling, relaxations, with or without gas, with scleral infolding or imbrications. Rarely we might have to use a macular buckle also, either as a alone or as a combined with a vitrectomy procedure. Some attempts have been done with suprachoroidal buckling as well in the literature. So let's start with some cases. 68-year-old female, one-eyed almost, other eye scarred CNVM. She had a posterior pole detachment which was extending beyond the staphyloма or the arcade area, with a full thickness macular hole which was picked up on the clinically as well as in the SSOCT. We did an ultrasound to look for the axial length and documenting the staphylomas configuration beneath the detached retina. And here we took a decision to go for a conventional vitrectomy with ILM peeling and C3F8 gas. She did well with type 2 closure. Some points we learn from these type of cases when we operate, especially in the myopic eyes with the ILM peeling, especially in the detached retina. We are operating on a lifted retina. So paradoxically, your staining of brilliant blue is more better because the retina is little opaque. So one gives an advantage, but the lifted retina has got its own plus minuses. The drainage retinotomy might have to be done if the SRF is little extending beyond the staphylomas, especially on a healthy retina. You might have to do so to drain the fluid. Subretinal dye, I think most of us have experienced this very often. We see the dye extending into the subretinal space and stain the changes there. I usually prefer a little larger peeling in these cases, especially try to go at least up to the staphylomas area, because I feel still the surface relaxation is more important when we do a complete good vitrectomy. So another case, 57-year-old male, had again an acute drop in the vision. He was one-eyed, the other eye was phthisis, had a large eyeball, measured axial length of around 30.5 millimeter. He had a deep staphyloma. Here there is no macular hole, but there's a macular detachment with an SRF. And you see the retina is quite healthy and quite thick enough. So here again, we went towards the vitrectomy again. And I think I spared the fovea when I relaxed the ILM, and with the C3F8, the retina got attached. Again, in these cases, little points which we pick up when we operate on ILM peeling in these myopic eyes, especially the on retina or little shallow fluid. The contrast is little compromised because of the choroidal atrophy. I think one all agrees with that. And most important is that the eyeballs are large, so our reaching the instruments might be little difficult. We might have to do a little posterior sclerotomies or take out the cannula troca, etc., etc. Some large instruments are also available from companies. And especially what I feel is that when we arc our instruments, especially in the deep staphylomas, we might hitch the retina and cause a tear or extra anything. And most of us agree that we have observed some firm adhesions along with the staphyloma edges and the blood vessels, and we might have a high risk of iatrogenic macular hole also if the retina is very thin in these cases. So I felt that the vitrectomy takes care of a majority of the traction maculopathy because surface of the retina, that is the inner retina, is the main pathophysiologically affected in these cases. So if you have to remove the cortical vitreous or the ERM or ILM, so most of that we can gotten away by the vitrectomy, conventional vitrectomy and the ILM peeling. Very few cases where we have a very deep staphyloma and traction maculopathy changes, we can again still go with the macular buccal. And if the staphyloma contour is not configuring with the retina and with a large hole, etc., so we might have to combine the macular buccal with the vitrectomy procedure. So let's go with some cases. 68-year-old male had a acute drop in the vision, one-eyed again, posterior pole detachment, very high axial length, I think more than 33 millimeter, with a very deep staphyloma. And if you see the OCT here, there's a macular hole and the retina is actually shorter than the staphyloma contour. We call this as a stiff retina. And over the retina, you have the surface with the ILM, which is quite taut. So in these cases, we took a decision that, okay, we'll combine the macular buccal along with vitrectomy, ILM peeling, etc. So oil was removed, cataract surgery was also done. The patient was doing well. In these cases, some points which we can pick up while operating these combined cases are that I usually prefer 23 gauge because of the rigidity of the instruments. Preferably valved cannula would be better. And one need to really confirm that all the vitreous has been removed from the surface of the retina. You might have to do multiple dye staining again and again. ILM depth perception, on the contrary, because you have indented the macula with the macular buccal before starting the vitrectomy, the depth perception might have to be little modified accordingly. And what I observed in these cases when we do combined surgery, because we have to titrate this buccal indentation when we are done with our FG, that is before the oil infusion. So at this point of time, the globe is quite risky for the sudden collapse or sudden hypotony, so which may result in a lot of choroidal detachment or hemorrhagic detachment, etc. So one has to be really careful with this. This was the learning thing what I observed when we do a combined procedure. Another case, 47-year-old female, again posterior pole detachment here. She came first time with a macular hole. We planned combined surgery, but when she took a decision to come for the surgery again, the hole had spontaneously closed and you could see only the macular detachment here. So we went ahead with only the macular buccal alone. In these cases, what we usually observe is the retinal opposition back to its RPE takes over a period of time, like normal our buccal, where the retina can take some more time to oppose onto the RPE. In these cases, sometimes learning curve, the titration of the buccal height might be one of the challenge, but over a period of time, one can get away with that. We have different ways to visualize the indentation, either by endo-illumination or by indirect ophthalmoscopy, etc. So what we have been using, there are a lot of buccals available in the market. We use T-shaped buccal called Morin-Devin Macular Wedge because of probably an easy procurement or the cost factor and little less messy. It's available as two components. One is put into the another to form a T-shape. That's the macular plate, what we see here. And this is schematic surgical. I don't have much time here to show. Schematic surgically, we place this macular plate with the support of the three slings over to the contour of the globe and supporting the staphyloma. Some of the complications is not that we don't have it. Couple of cases we had subretinal hemorrhages around the buccal or the staphyloma edge while operating, and it's self-resolving most of the cases. You might have a serious detachment at the end of your surgery or in the post-operative period, which also can be managed with the medication. One of the little dreaded complication we had encountered, one intra-op and one post-op, would be a hemorrhagic choroidal detachment, but further management is like any other hemorrhagic choroidal detachment with a drainage and vitrectomy further. Over indentation or under indentation in the learning curve, one might see, but over a period of time, you get adjusted with that. High IOP in the post-operative period is again one of the very commonly noted ones. So I usually try to avoid a proper glaucomatous eyes to consider for macular buckle in these cases. And however much you do you place the buckle in the center, you might sometimes see the decentration or sliding of the buckle from the fovea in the early post-operative period, and but you might have to counsel this to the patient before. So it depends on the staphyloма contour risk exactly. So to conclude, taking forward a case of MTM, most of the cases, if we are observing, it should be around 4 to 6 monthly with a well-documented wide width OCT, preferably 9 to 12 millimeter. If SSOCT is available, good. One need to really educate these patients that the myopic degeneration progression starts at 40 when the patient is having its productive lives, which is little earlier than ARMD. So home Amsler would be a better guide for them to come back to you if there is any symptoms. Coming to the macular buckle, you need to have a very good refractive status documented before the surgery, or especially when the patient had underwent a refractive surgery before. You need to counsel them that you might have a hypermetropic shift post-surgery of certain diopters. You need to have a very good wide width OCT scans before the surgery. And ultrasound B scan is a mandatory one to look for the details of the staphyloma characters, including the axial length. Of late, past about 2 years, I have been doing the MRI scans also in a 3D imaging, which helps myself to assess the staphyloma features. Especially sometimes of late, we are even contraindicating the macular buckle if we are getting an opinion to consider the buckle or vitrectomy based on the MRI scan, because the staphyloma might be very atypical when you see in the MRI, which is not seen from clinically. And take home would be that one has to be really aware of the surgical risk, which might outweigh the benefits, especially when we are operating in these extremely large eye, and especially in the compromised setup. Thank you very much. I thank Dr. Rajiv, Dr. Mohan Rajan sir, and JB for giving this opportunity.
Wonderful, wonderful, Pradeep.
Thanks, Pradeep. It was really a great insight. And I would like the panelists to talk, or anybody else who wants to give any comments and differ in the opinion what Dr. Pradeep said.
May I ask a question, Rajiv?
Yeah.
Which company makes this macular buckle, Pradeep?
This was before from FCI, sir, and now it has been taken over by Zeiss. It's available in our in Delhi, one of the pharmacy. We have the address and all. Devin Care there. We can procure from there. It's quite cost effective. It costs around 2,000 or 2,500 rupees, I think so.
Great.
Can I ask a question? Excellent talk. Very nice.
Sir, I think you would have heard a lot of times.
I've heard this.
No, it's not a lot of time.
But anyhow, each time, it's a learning experience. Unfortunately, in this part of India where I work, the incidence of this condition is not very high. High myopia probably is less common here. But nonetheless, I just wanted to ask you 2 questions. You said you decide on the macular buckle based on the depth of the staphyloma. That is, if the staphyloma is very deep, then you plan to do a macular buckle. So, I mean,
that is
be more precise as to how do you really analyze and decide as to whether to have a buckle with a vitrectomy, or you think that in many cases you can first do a vitrectomy, ILM and gas, and if it doesn't work, then as a second stage do a macular buckle.
So usually first depend on the clinical examination. Even if sometimes the posterior pole detachment, you're not able to assess the staphyloma, even in the other eye, somehow you will get some clue how deep the staphyloma is. Then when you see clinically, you can make out whether the retina is still elastic or little stiff. and which you can depend on the OCT to give you that clarity about the rigidity of the retina, whether the surface is quite rigid. And I look at the retinal, the overall width of the total retina, because sometimes in, I don't know, one of the cases had, the retina will be very thin, it will be stretched out, and you will not even have a structural, some tissue of the retina still. So in those cases, there's no point in going inside the eye and doing that and causing much more iatrogenic problem. So in that case, it would be more better that you support as a simple macular buckle without going into the vitrectomy.
What about the width of the staphyloма? Does it have a bearing? The width?
There is an article which measures the staphyloma. I usually measure according to the ultrasound, because that was the one we started with. So less than 2, 2 to 4, 4 to 6, and I think we have still operated around more than 4 millimeter also. That comes under the category of severe staphyloма. And when you obviously know that there is some shortage of the retina, so which cannot, then you try to combine both the surgeries from the vitrectomy and the macular buckle. Yeah.
Can I ask Rajiv one question?
Please.
One comment, like what Pradeep mentioned. Once again, Pradeep, nice talk. When you mentioned that it's not easy to see the macular hole, sometimes it can be scary sometimes when you are operating where the macular hole is.
True.
I saw in one of your cases of macular buckle post-op, the height was reducing in the subsequent OCT. Do you see that often, that the right height of the macular buckle reduces? And if so, can it also be associated with the recurrence of a macular pathology?
Yeah, I had imagined this, but it doesn't happen. So what happens is the height which is little over indented I have never seen that it has come back over the whatever the period we have been doing it. But what has been under corrected, like initially there were 2, 3 classical. I used to always show those cases as a failed macular buckle. So there I presume that I had given a very good indentation, but post-operatively I could just see that hardly there was any indentation or almost nil. So those cases invariably recurred after the oil removal, and I had to go back again to laser the macular hole back to its place. So the over indentation do not usually go back, but the under indentation you can easily pick up and can expect that there might be a recurrence.
So do you recommend giving a much higher height in the initial surgery?
Probably again, that's a learning curve. Nowadays, a little more modification. It's little that small point of titrating the buckle is little challenge still, and it comes over a period of time.
I think we'll go for the
very nice presentation. One small question I had is that when you're doing only a macular buckle, how do you titrate your height? I mean, you're looking at it through an indirect, and you try to get a full settlement at that point of time, or you indent as much as possible and then leave it for resolving on its own?
No, madam. Usually on the table only, you can definitely get a good height, whatever you can intend into by pulling the other 2 slings towards the nasal side. So the temporal one, it actually gets into the position. The nasal 2 slings is actually the one which titrates the height. So while pulling, it's like similar like our buckle. When it is pulling, I use indoor illumination with chandelier. You can either use an indirect ophthalmoscopy, but chandelier would give you a little more 3-dimensional depth perception, because even when you are pulling towards the disc, you can still titrate and get back a little more so that you don't hitch the optic nerve at that point.
Will IOCT be useful in this?
I tried, sir. We had, but it was an SDOCT, so it didn't pick up much. I tried in first 2 cases on the table. It was not much coming back. Maybe the latest OCTs, IOCTs might.
Swept source OCT on the table. I think that is something which will come soon. I don't know whether it is anything which is available. We'll go to the next talk. I think the next talk is by Dr. Rupak Kanti Vishwas. And he does one novelty. He uses autograft for macular holes. And I think what he will be talking on is my approach in managing macular holes. Dr. Rupak. You're muted.
Rupak, you can share your screen. That's fine.
That's fine. Rupak, we don't hear you.
Can you hear me now?
Yeah, we can hear you now.
Okay.
Can you make it full screen?
Yes, yes.
Put the slideshow.
Is it there?
Yeah.
Yes, boss.
Okay. I would like to thank Dr. Rajiv, Dr. Mohan Rajan, and Dr. JB for this wonderful opportunity. But I was just thinking of, for the macro hole, what are the things I should not talk about it. So in this approach, the standard approach for a macro hole surgery is doing a vitrectomy with ILM peeling and gas tamponade. But let me start with this other side, the flip side of it. It can have a spontaneous closure as well. So there are about in a small group of patients when you have very small macular hole size, less than 250 micron, and the spontaneous closure rate is around 4 to 11%. So on that, the most important is that what should we decide about the treatment protocol for the macro hole. We still now follow the Dongas classification of stage 1A, B, 2, 3, and 4. But over a period of time, as IVT's classification came in, and then again SDOCT classification, so more and more we are focusing on whether there is any vitreous attachment and the size of the macro hole, so which gives us, how we should proceed about it. So if you look at here, then the SDOCT classification shows a smaller hole of less than 250, and the medium size is 250 to 400, and a larger hole is more than 400. For all practical purpose, we may put it in a little different way. So less than 250 is maybe a very small size, 250 to 400 is is a small size, and 400 to 600 is a medium, and more than 600 to 800 is a larger hole. So that's what we usually get in the practical purpose. So just a brief overview of the pathogenesis and of the management of the macro hole. This review article has a very good insight of it, how the vitrectomy. So if you have a vitrectomy versus non-vitrectomy, so vitrectomy obviously has a major role over it. So almost near about 48%, 84% of comparison vitrectomy and non-vitrectomy. People have tried of giving even the two extreme sides. People have given in a non-vitrectomized eye, given injection of intravitreal expansile gas, and saw near about 2/3 of the patient they had occlusion. Especially overall is 2/3, but for the smaller hole it goes up to almost 80% of those cases. On the contrary, the other group here, there is no vitrectomy, only gas. The other group is having vitrectomy and the gas. So almost they also have an equal size of 2/3 of them also had a successful closure, with almost 70% having the closure in the smaller size of the hole. So this is a very interesting phenomenon. The internal limiting membrane peeling versus the Uvea flap, which is the most burning topic for nowadays, whether which form of ILM peeling we do choose for our cases. This study has clearly shown that there is almost near about, they have a very large series of studies of almost 620 eyes they have done, and overall with both the things is having the success rate around 85%. Here, if it is more than 5%, more than 400 micron size, that is by description, it is a moderate to large size of the hole. So the success rate achieved is 95% in case of inverse flap, compared to 78% in standard ILM peeling, so which is statistically significant. So probably the more we shift towards the larger size of the hole, the inverse flap has a good result. But when the axial length increases, is increased in a myopic macular hole, the success rate is significantly different. Only ILM peeling gives only around 40%, 38 to 40% of success rate, vis-a-vis 88% in the inverse flap technique. So this is more important information when you have a larger size of the eyeball. So inverse flap, that gives a good result, whatever size of the macular hole is. So I think we are all here, our majority of us are VR surgeons here, so they do it on a regular basis of this inverse flap technique. So just to have a very short glimpse of it. So this is, and then you can just gently put it over with the soft tip cannula. So the confusion starts when you have a persistent macular hole. So what about for those, the residual 10 to 15% of the cases when you have done the surgery and you have landed up having a persistent macular hole? So there are people who have given any kind of thing. So starting from the amniotic membrane, then lens capsule, then ILM plug, and the serum deposit there. So everything has been tried out because as there was no solution, still the research is going on. And this group from Italy has clearly demonstrated that ILM plug, free ILM plug with gas endotamponate has a good result out of this. So they have also near about 8 cases they have done. Here they out of 5 cases had a successful closure with this persistent macular hole. But again, 3 cases out of 8, they could not have a free flap, could not close that hole. So almost around 2/3 of the cases success rate. So this is a short glimpse of how we do it in a case of macular hole. After this, probably, yeah. So once you have a free flap, yeah. So you have a free flap, you can harvest it from the other area, and then for modified, another technique is that for a modified foveal and advancement technique by giving an injection in the periocular hole area for a large persistent macular hole. So this is a very interesting study of 10 eyes with a persistent macular hole. They have injected the average size was almost about more than 1000 micron size, and they have injected except the nasal part, they have injected inferiorly, superiorly, and temporally with a 40 gauge and 39 gauge needle, and gently with the soft tip cannula they have massaged and put those whole margin closure together, and they have achieved almost 100% of those success rate out of 10 patients. All the 10 eyes they have with almost maintained or a little improvement of the vision. But most important striking feature is that all the cases have the loss of ellipsoid zone in all those 10 cases, probably because of those significant manipulation at that area. The hot and burning topic comes here as autologous neurosensory retinal patch graft as for the persistent macular hole. So I would like to share a small video here, which we are doing since 2015. And in fact, today I have seen the first case which I did in 2015 had a graft loss though. So this is here we go. So after a complete vitrectomy, this is a vitrectomized eye is already. So we have a different size of the macular hole. So here preoperatively you decide whatever the size of the macular hole, and then 15% have increased the size of that hole, and then calculate it and put it here. And then with this is a trifine which has a sharp edge, and around 350 micron there is a catch over there. So once you do this trifining over the retina, it does not cause that much of bleeding to the choroid area because of that stop inside. And with the left hand you can just have gently hold those macular graft which has been taken from there, and under this part was done under fluid, and then we did a fluid air exchange with the other hand and then gently put it there and tuck with this soft tip cannula. Compared to the other group where the majority of the people they have done is the larger size of the retinal graft has been taken out and then put it over there, which is actually act as a scaffold vis-a-vis here the end-to-end contact in case of graft source junction, and that causes probably the aberrant neural regeneration. So that is the hypothesis going on over here. To conclude, if you have an ultra small or very small hole which is less than 500, initially we can observe, and if the vision is very good and there is no deterioration, so probably if you have a 6.9 or 6.6 vision and very small hole, then we can wait for 3 months, and if it does not resolve by its own, then we can definitely proceed for this. Or if there is deterioration, we can always proceed for the surgery. Smaller hole, which is having obviously a standard approach, having a very good result. Moderate size, 400 to 600, the standard approach, rather than the inverted flap technique, will have a better result out of this. But for the large hole and the myopic macular hole, inverse flap is probably the choice. And for persistent refractory hole, ILM free flap, margin augmentation, and probably the autologous retinal transplant is the way out. But again, we have a lot of options are here, and our significant research is needed till we come to a conclusion for a persistent macular hole. Thank you.
Lovely, Rupak. Very nice. Rajiv?
Thank you, sir. Thank you.
Yeah, thanks, Rupak. It was excellent talk. And I think from the panel, any comments? I think he gave a good idea on how he manages macular hole. Anybody differs from this?
Rajiv, can I share my experience?
Please, please.
Yeah, I had one myopic eye with macular hole and detachment. Maybe the axial length is about 30. I tried first surgery, ILM peeling and C3F8, it worked. But the moment gas would become less, it would detach. So second surgery was with amniotic graft. That also worked till the gas was there. And it was beautifully attached. Again, the hole opened, and the third surgery was with autologous retinal graft, and that has remained under oil. So probably that's almost 6-7 months the retina is attached, And I have done 2 or 3 amniotic membrane graft, but this was the first case where it did not work. Otherwise, amniotic graft has also worked well. I just wanted to share my experience.
Sure.
What about the function of the retina? I want to know, Rupak.
Yeah, so that is a $1 million question, because the thought process came from there. If you put an ILM free flap or amniotic membrane or the lens capsule, so the gap can be filled up, but this is most of the time it is filled with a scar tissue only if we go for the SD-OCT analysis, because it cannot regenerate a retinal tissue there. So that was the thought process, is why not to put a retinal tissue, but obviously we cannot regenerate one more macula there. The rod and cell, the photoreceptor concentration will not be as high as macula for the other areas. But again, a retinal tissue. The concept has come from another process where we used to learn from the physiology that if we have a cut end of the bare neural area, then there is always a possibility of aberrant regeneration. And the similar process is similar concept is being used for the corneal sural nerve transplant there in case of corneal neurotropic ulcer. And in these cases, we have a documented.
Yeah,
we have a documented.
Please, you had some multifocal ERG studies, I remember, Rupak.
Yes.
Yeah, please share that.
So we have a multifocal, because of the short of time, I could not share it here. We have a multifocal ERG, which is showing a significant spike in those successfully closed graft cases. And we did, I don't have the access of microperimetry, but I did a central 10-2 of those cases, and I got near about 25, 26, 27, like these kind of values in the central area of those cases. And my experience is that this is a fortunate or unfortunate lady. She had a bilateral macular hole, and I did surgery at the first case. Both the macular hole failed, and I did both the macular hole, the retinal grafting. And she is now reading newspaper. So this is, I just wanted to share my experience.
Amazing.
Thanks, Rupak.
Rupak, excellent talk and very good comments.
Thank you, ma'am. Thank you.
Only thing is that have you ever lost a flap when you were doing an autologous retinal transplant?
Yeah, the first two cases when I started in 2015, in first two cases, I actually did not consider that there is a graft shrinkage portion of it. So initially I put the similar size of the graft there, and over a period of time, the graft shrink, and there is the one graft has, that's what I was telling, the first case which I did, there's a subretinal migration of that graft. And the second case was a graft loss. Then I realized, I analyzed what is happening there. So after that, I have increased it to 15% of the size, considering the graft loss, I mean the shrinkage size. And then after that, they are successfully staying there.
And when you sort of pull it from the area where you've taken it right up to the macula, do you do it under air or do you do it under PFCL?
No, I do it under air only. So the trefination, I do it under fluid, and then I take it in the fluid itself. I put it with the ILM peeling forceps. I hold it with one end and carefully, and then with the other hand, I do fluid air exchange, and with this I gently put it there. Simply what I have shown it there.
Wonderful.
Wonderful.
Great.
So
Great.
just one thing I wanted to add. Very nice presentation, Rupak. I haven't done many, but in one case that I did, so what Dr. Kerobi mentioned that you can sometimes lose the flap. So if you do it under PFCL, and if you put the flap and without doing air exchange, you directly do a PFCL oil exchange. So that allows a minimal disturbance of the flap. So then the risk of losing the flap is not there. So very much like when you do a peripheral ILM flap also, you would probably do the same technique that you drag the ILM under PFCL, leave it at the hole, and then just exchange it with oil. So then you don't lose your flap.
Yeah,
So,
can I make one comment?
Yes.
Yeah, Raj.
Yeah, good presentation, Rupak. Overall, nice overview. I just wanted to bring to your attention about one article which I have published in IJO last year along with my fellow, where in a retinal graft patient, we had done the multifocal ERG, and the response was much less compared to the normal eye, and it has to be expected. We can't expect a 6x6 vision in a patient where we take a graft from away from the arcade, where the cone or rod density is much lower than the fovea. So just cannot expect, to say that I'm still hoping for an improvement further. But yes, this patient also improved by 2 lines. It's probably good, better than probably just leaving it alone in some cases. But overall, yes, there was some response. But it was much less than the fellow eye.
So I agree with Dr. Raja also that you cannot expect too much of improvement, but there are some circumstances like you have a macular hole with RD. So you have to settle the RD now. So if it's a large hole and you've already done a ILM peel and it is not worked, so then probably this will come to the rescue, because even if it doesn't improve functionally, you at least get a reattached retina and patient gets peripheral vision. So
very true. Very true. I agree with you, Raja. But only thing is that even to Dr. PK also, the reason of I have not used till now the PFCL is that because the hypothesis here of the direct end-to-end contact. So because if we use silicone oil or PFCL, that may have a hindrance between these two. So that is the reason probably I have not used as of now. But all my cases is not associated with RD. So these are all failed macular cases, failed macular hole cases with attached retina. So that's how I could manage with this. But again, if you have a RD with macular hole, then probably that is the way out.
So thanks, Rupak. It was really a good talk, and we could learn a lot from your experience. And I think we'll go for the next talk. We have Dr. Raja Narayan.
Thank you.
And Dr. Raja will talk to us about steroids in serosanguinous maculopathy. So we are all used to using anti-VEGF in all forms of serosanguinous maculopathy, AMD or a PCV. He will tell us his experience of using steroids in serous maculopathy. Raja.
Thanks, Rajiv and Dr. Mohan Rajan for the kind invitation. I'll be, actually, I prepared it like more of a study kind of a talk, not just a case, but I will just share. This was presented, I'm sorry, there is some audio in this. Okay, so this was presented in the at the ASRS. A part of this, after that we have worked, Rajiv and myself have worked on this and modified some of the patients which we have. So in this, what we had was patients who had a significant amount of fluid, both intraretinal, subretinal, as well as PED after multiple anti-VEGF injections. We wanted to see if steroids along with anti-VEGF injections can work in these patients. We had a subset of AMD as well as PCV patients. Overall, ultimately, we had 17 eyes.
Is it a slideshow, Raja?
Unfortunately, there was some audio which was coming. That's why I
Okay.
have had to go to the regular show mode. So what happened was in that we had 12 eyes of PCV and 5 of AMD, and the mean number of injections which were given before we gave the Ozurdex injection was 4.5, and the number of mean follow-up after the dexamethasone implant was almost 1 year. As you can see here, the thickness reduction was significant after adding Ozurdex injection. In fact, in all these cases, there was not more than 10% of reduction of OCT with the previous anti-VEGF injections. But after the Ozurdex injection, there was a substantial reduction in the OCT thickness. Unfortunately, BCVA visual acuity was same before and after the injection. But this is something which has been known in large trials also earlier. In AMD, unfortunately, as of now, even today, we are happy vision is maintained and the number of injection is reduced. So we are looking at one, number of injections should be reduced even if the vision is stable. Yes, it would be good if we can improve the vision of these patients somehow, but at least at this point of time, the main crux is that if we can reduce the injection frequency or the burden. So the injection free interval was significantly reduced from 30.2 days to 100 and close to 160 days. That's a big difference in the number of months of injection free interval. This is one patient where, if you can see the top two, this was before the Ozurdex injection, and after the Ozurdex injection, a few weeks and 2 months later, there is no fluid. Even the PED has reduced significantly. Now, PED reduction is something which we don't aim for, but we have known that with aflibercept, it is more than ranibizumab and bevacizumab, the reduction in PED, and with brolucizumab, it's even more, the PED reduction. Although PED reduction by itself does not improve the vision in any of these patients. This is another dramatic example, a patient who had received numerous injections. We had switched all multiple injections, and immediately after the Ozurdex injection along with ranibizumab, this patient had substantial reduction of the fluid and it was maintained. But all these patients at some point do get a recurrence of the fluid. At that time, we have to re-inject these patients. So I would like to ask the panelists, when would they look at combining dexamethasone with anti-VEGF? Would they go in for brolucizumab now as another option, last option, instead of combining with dexamethasone? And would they repeat dexamethasone implant whenever there is a recurrence? Thank you.
Thanks, Dr. Raja. Dr. MPV, ma'am, your opinion, because I'm sure you have used some of the cases, steroids and especially PCV. Your opinion on that, ma'am?
Yeah, thanks, Raja, for a nice talk. And I have used a combination of aflibercept with dexamethasone implant for one of my single-eyed patients with a very large pigment epithelial detachment and exudative PCV. I was not able to go beyond, say, 3 months of aflibercept, even at the best time to keep her stable because she had a lot of intraretinal fluid. And I spoke to Raja also before I gave it because combining two of the most expensive drugs at that time was not something that I was very enthusiastic about. And there was a very dramatic response in terms of resolution of intraretinal fluid. Though the overall lesion size remained the same, and I was extremely happy, but it probably gave me a benefit of just 1 month in terms of retreating. And then when I raised the issue again with the patient, she said the vision didn't change much, so let me go ahead with only Eylea. So, but I have looked at some of my older patients where I treated PCV with PDT and steroid, and I found that a couple of them did well. But that's all.
I think PCV, it has some role because even in our subgroup analysis, Raja, we did find that PCV probably acts better as compared to AMD. So
yeah, that's true. That's true.
Yeah,
And
yeah.
we in the subgroup analysis, which Rajiv actually helped us. Yes, definitely, we found even the different compartments of fluid which we are seeing, intraretinal, subretinal, PD, the response was better in PCV. All the visual acuity difference, yes, it's not different.
Actually, you can give 2 milligram of triamcinolone. Even that works for 4 months.
Yes.
You don't have to give Osudex. Osudex is quite expensive. 2 milligram of triamcinolone doesn't have much of side effects like glaucoma and cataract. And therefore, I have given 2 milligram triamcinolone, and even that works for about 4 months. So, I mean, that's also very...
Yeah, I agree, Dr. Giridhar. Yeah, we have also given triamcinolone, but in this subgroup or this study specifically, we have looked at only the Osudex implant. Yeah, I mean, if someone is concerned about glaucoma, those issues, but yes, I agree that triamcinolone can also be.
Can also be. Dr. Parveen, your view?
I think this concept, I think Dr. Mahesh, Dr. MPS is also one of your co-authors for this, I think. He, if I'm not mistaken, you look specifically for the hyperreflective foci. So if you see the hyperreflective foci on OCT, so that is considered that probably a steroid injection may be more beneficial. And recently there has been a couple of articles, there have been on use of suprachoroidal steroid combined with anti-VEGF for PCV, especially large hemorrhagic ones. So when, instead of giving an intravitreal Ozurdex, probably you could also consider a suprachoroidal triamcinolone, which will reduce the cost, it will reduce the incidence of cataract and reduce glaucoma. And that has been done in a couple of articles which are recently published. So maybe this is the next step that we are all looking at, that steroid we can combine in some way without the complications, and suprachoroidal steroid is probably also one option.
I think it is a need because PDT is not there, and especially in PCVs, we want alternative now. So I think we more and more use of steroid will start.
A cheaper alternative is Ziv aflibercept, because even that gives comparable results, you know.
No, we have looked at all patients with only anti-VEGF who are not responding. Even many of our patients have received Ziv aflibercept or even aflibercept, and still there was no response. We're looking at something as the last kind of thing, you know, throwing the last dice.
It's a good study. And actually, I mean, only thing is in the subgroup analysis, I mean, you showed a case where there was a 13-month quiescent period, isn't it? 13 months.
No, that was 6 months. 6 months quiescent.
6 months quiescent period.
But many patients do have recurrence even earlier, at 3 months also, 4 months, they do have recurrence.
So how do you decide? I mean, what was the selection of patients like? I mean, was there any particular this thing? I mean, these are patients who have received, they are not treatment naive patients. They are all patients who have...
Yeah, they are not treatment naive. All of them have received 3 injections. There was no reduction or hardly any reduction, less than 10% reduction. Now, many of them were not switched. They were directly given this combo. Some of them have received all kinds of injections and still they were resistant. But overall, they were resistant to anti-VEGF.
So basically non-responders to one anti-VEGF, right? I mean, 3 injections you give.
Yes, yes, yes.
Fantastic study.
Nice, nice. Okay. So,
And any other comments from the panelist? Otherwise, we close the session.
I mean, it's gone much beyond Mohan's.
Yeah, it has gone more than.
No, I have one or two questions from the audience. We'll quickly, I think it is for the. Let me go through that. Give me some time.
Actually, one question is from Dr. Shishir. Any experience with oculoplasmin for VMT by faculty? Any rationale in stage 1B? I think we don't have acroplasmin today in India.
Yeah, even then, people are not used now. Even the US, Europe, the company has switched hands. The drug is no longer with Alcon.
Yeah.
So, so right now it's not. Nobody is using. In fact, you can give saline injection or even pneumo and a gas injection. All of them have some percentage of success. So at this time, it's a moot question. Nobody is using acroplasmin.
Sure. Dr. Mohan, any other questions from
Dr. Anjali Mehta? This is for the Uvea session. Are there any special precautions when injecting Ozurdex in active cases of uveitis in terms of the injection itself?
No contraindication.
Sir,
in fact, it will work well.
It will work well, but sometimes in patients of uveitis, there is a little bit ciliary shutdown or there is little lower pressure. So you have to be more careful. You can drag the pars plana epithelium. So, you want to be more sure, especially if you're giving it in patients where there is some hypotony. That's the thing. And sometimes after giving the Ozurdex, you can have lower intraocular pressure if the function of the ciliary body doesn't pick up. So those are the two issues when you're giving Ozurdex. Hypotony, you need to be careful, and post-injection hypotony can also be an issue.
Yeah, that's right.
I think more important, like it's in the vitrectomized eye, you need to be more angled when you are injecting Ozurdex so that you self-seal it rather than, because it's a 23 gauge. So sometimes hypotony can happen even after, if you go more perpendicular, you can have a hypotony like that. So I think
that's the whole problem. When you have uveitis, you want to go more perpendicular because of the edematous ciliary, the pars plana and the choroidal tissue.
I think we have answered all the questions, and have we come to the end of the session? Any more suggestions from the panel? Comments from the panel?
I think we can have a single specialty program because two specialties.
Yes, two specialty also takes time. Actually, I suggested you one specialty every time.
We had all the specialties and we did 4 hours. And we did just 2 specialties.
Yeah. So my suggestion was have one specialty in each webinar.
Or let us have only half specialty.
No. It's better to have 2 specialties with lesser talk, but which are allied, like Retina, Uvea, or Pediatric, and Squint.
Sure.
So.
Yeah. Anyway, let me come.
One comment. Congratulations, Mohan, JB, and Rajiv. A very, very, very good sessions.
Very good session. I think it's a very good session and very exciting, very stimulating, very educative, very useful. It's been a learning experience for all of us. I would like to thank all the 10 panelists, all the 10 speakers, and the 2 fantastic moderators, JB and Rajiv, for being with me, with all of us, to make this program a very big, grand success. Because many people have logged on to the YouTube as well as the Facebook, and I've been getting a lot of feedback from this already. And I'm sure this SN Alumni webinar will be a future, it will be a success in the future as well. We meet again next month. I want to make the Giridhar, to answer your question, I want to make 2 specialties. For simple reason is that if you have only one specialties, the people may not be able to log on because so many webinars are occurring now. If you have 2 specialties, for example, both Uvea and Retina people are interested will join. So that is the advantage of increasing the number of participants. So that is the idea of having two specialties. Probably we'll cut down the talks and have more panel discussion or something like that.
No, sir, for the audience, they can walk in, walk out for their interesting talks or sessions. But for the panelists, they have to sit through all their sessions.
Raja is having webinaritis now.
All symptoms of webinaritis.
Yeah.
Whatever it is. Yeah.
Thank you so much.
I'd like to thank
thank you, everybody. Thank you, everybody.
Thank Allergan for sponsoring the session. Because Allergan, as you all know, we discussed Osidex. I'm sure all of you will use Osidex only. Next webinar also I'm asking Allergan only to sponsor. At least till the next webinar, use Osidex. Okay. And second thing is, I would like to thank Sai Krishnan and Manjula of the Numerotech company of Coimbatore. They're doing the back end work and they're absolutely flawless. They've been doing a fantastic job communicating and getting the Zoom platform, getting the YouTube platform, getting the Facebook.
It's 10 o'clock.
And a huge amount of participants also. I would like to thank. My special thanks to JB and Rajiv Raman. I think they have been the pillars of the Shankar Netra alumni. Coming out with brilliant ideas. They have decided the faculty and all the faculty, all the presenters were really fantastic. Okay. And we are very proud that we are part of Shankar Netra. Yes.
Mohan, you are also one of the pillars.
No, I'm not. I'm just.
You are the main pillar.
Yeah, central one.
Thank you so much. Thank you so much.
Thank you.
Thank you.
Bye.
Thank you. Good night.
Good night.
Thank you.